200 মার্কস পাইছে, এত সুন্দর এগুলাই তো আনসার।
আমারে বলে কি ইংলিশ স্কুলে তো ইংলিশ ভালো বলবেই, আমি বললাম দ্যাটস হোয়াই ইটস আ থার্ড পয়েন্ট। এসে দিছে সেটা। মেসার আসছে দেখলাম না?
হ্যাঁ আমিও দেখলাম সেটাই।
আপনাদের ওই যে ইগুলা ভালো হচ্ছে, সেদিন আমি ক্লাসটা পুরো একটা জয়েন করলাম, যে এমআর এর ইয়ে ছিল যেটা।
হ্যাঁ প্লিজ এরপরে অন্য ক্লাসেও জয়েন করো,
মানে আমি সময় পেলে জয়েন করব।
হ্যাঁ হ্যাঁ আমরা তোমাকে ফোন দিয়ে আগে জানাই দিব। হ্যাঁ প্লিজ, কারণ তুমি তো অনেক একাডেমিক, তোমার এক দুটা কমেন্টস পাইলেও স্টুডেন্টদের জন্য লাভ আছে। প্লিজ নামটা কি আসলে আপনার নামটা কি আসলে বলবেন না? ওয়াদুদ আমার নামটা এইভাবে লিখছে কেন?
আপনি টাইপ করেছেন ম্যাডাম, আপনার ওখানে ম্যাডাম কি আপনার ইমেলে ঠিক করে নেন আপনার যে কম্পিউটারে।
ও আমার ইমেলে ঠিক করে ফেলবো। আচ্ছা
আপনার ইমেলে
আমরা লিখছি নাকি?
আপনার ইমেল না, আপনার
ওটাই দিছে।
ম্যাডাম ম্যাডাম আপনি রিনেম করতে পারবেন।
রিনেম করবেন ম্যাডাম।
হ্যাঁ এটা আপনার পুরান আপনার নামটা তো এইভাবে না, আপনি কিন্তু সব করে ক্যাপিটাল দিয়ে লেখেন।
প্রো লিখি না, প্রফ PRO এন্ড প্রফ। হ্যাঁ সব
প্রটা ভুল হইছে, এটা প্রফ লিখতে হবে।
প্রো হ্যাঁ প্রফ লিখতে হবে।
এইটা ঠিক করে দাও না।
স্যার এটা আপনি করতে পারবেন স্যার।
আমি করে দেব।
জি স্যার মহসিন স্যার আপনি ঠিক করতে পারবেন স্যার।
আমি করে দিচ্ছি।
আপার নামে একটা জিনিস মালিক শব্দটা লিখতে হবে, পুরো নামটা লিখতে হবে।
Fazilatul-Nesa Malik। হ্যাঁ আর এন্টো ক্যাপিটাল এন হবে,
ক্যাপিটাল আপার তিনটাই ক্যাপিটাল লেখে। আমি এগুলো ব্যাপারে খুব খুঁতখুঁতে আপা, কারণ অভ্যাস হয়ে গেছে বিভিন্ন ওই যে সায়েন্টিফিক সেক্টর হিসেবে এপিবি কাজ করতে গিয়ে এগুলো খুব খেয়াল করতে হতো, কার নামের পরে কে কিভাবে লেখে, কে মোহাম্মদ ই দিয়ে লেখে, কে এ দিয়ে লেখে, কঠিন জিনিস। মহানন্দে দই চিরা খাচ্ছি, দই মুড়ি খাচ্ছি।
থ্যাংক ইউ সো মাচ, থ্যাংক ইউ। খুবই স্বাস্থ্যসম্মত খাবার খাও।
আমাদের অলরেডি 71 পার্টিসিপেন্টস।
72
72
74
74 কিছুদের মধ্যে 100 হয়ে যাবে।
এটা ইয়ে বাদ দিয়ে, ফ্যাকাল্টি বাদ দিয়ে।
আমরা কি কখন আমরা 7:35 ইউজুয়ালি শুরু করি তাই না? আর মহসিন তো আমরা বললা যে আমরা 40 মিনিটের আমার প্রেজেন্টেশন, তাই না? ইনশাআল্লাহ
আপনার অসুবিধা নাই, আমাদের এখানে দেখছি আমাদের সময়ের অতিরিক্তই যায়, কারণ উই ওয়ান্ট টু গো এ লিটল বিট স্লো, বাট খুব জিনিসটা বুঝায় তাই খুব ভালো হয়।
হ্যাঁ হ্যাঁ অ্যাবসলিউটলি আই উইল ডু দ্যাট।
এবং এটা সবচেয়ে সুবিধা আপা, এখানে আমার ঢাকা মেডিকেলে কিন্তু আমাদের ক্লাসে কিন্তু আপা এই সিস্টেমটা করছি, ওখানে আমরা টিচাররা ক্লাস থেকে বেশি স্টুডেন্টরা একটা টপিকের উপর তারা বলে। আমাদের ওখানে নিয়ম হলো, ধরেন ও ফার্স্ট স্লাইডেই আমি হাত তুলতে পারি, ফার্স্ট স্লাইড দেখানো পড়ি, দরকার পড়লে ওই স্লাইডে একটুখানি কথা হবে, টিচার কথা বলবে, অন্য কেউ কথা বলতে পারে, এরকম করে করে আগানো, মানে প্রত্যেকটা পর্যায়ে অল্প অল্প করে ডিসকাস করে করে আগানো। তার ফলে হয় কি ক্লাসটা 1 ঘন্টার হয় না, 2 ঘন্টা হয়ে যায়, বাট এট দ্য এন্ড অফ ইয়ার দেখা যায় পুরো ক্লাসই ইনভলভ, পুরো ক্লাসই কোশ্চেন করে। তারপরে শেষ হওয়ার পর আমি তখন শুরু করি সবাইকে যে কোশ্চেন, প্রপার কোশ্চেন না করতে বলে দাঁড়ায় থাকতে হবে। তুমি ভালো একটা কোশ্চেন করবা, ফাঁকিবাজি কোশ্চেন করলে হবে না, তাইলে তুমি অ্যাপ্লাউজ পাবা। অনেক সময় বলি যে দাঁড়াও, কারা এখন পরীক্ষার্থী আছে, তারপর যে ভালো কোশ্চেন করতে হবে সে বলবে। তার ফলে সবাই আপনার ওই যে ইনভলভমেন্ট ভালো পাবে,
সাবজেক্টটা নিয়ে চিন্তা করে। হ্যাঁ
আসসালামু আলাইকুম ম্যাডাম।
ভালোই হয়।
ভালো আছেন?
চলে আসছে।
জি ম্যাডাম ভালো আছেন? আসসালামু আলাইকুম স্যার।
ভালো আছেন?
তাআলাইকুম সজ্জল।
জি
ও আমার বাচ্চা, ও যখন বাচ্চা ছিল তখন আমাদের সাথে কাজ করছে, এখন তো অনেক বড় হয়ে গেছে।
ফার্স্ট জব এমবিবিএস এর পরে ফার্স্ট জব, এবং কার্ডিওলজি ফার্স্ট ট্রেনিং, কার্ডিওলজির ফার্স্ট ট্রেনিং ম্যাডামের আন্ডারে।
ও তখন আমার ওখানে চেম্বারে স্টে হিসেবে কাজ করতো,
তুমি রেফার করছিলা?
আমি রেফার করছিলাম।
ওয়াদুস্তার রেফার করছে না, ওয়াদুস্তার রেফার করছিল
যে ওখানে যাও, ওখানে গেলে ভালো হবে তোমার।
থ্যাংক ইউ ম্যাডাম, থ্যাংক ইউ স্যার।
আল্লাহ
95 অলরেডি 95
আজকে আপা ওই যে
আমরা 1 মিনিট করব আপনারা 1 মিনিট স্টার্ট
ইকোর উপরে তো এখন সকালবেলা একটা সেশন হয় প্রত্যেক শুক্রবারে আজকে ডপলার ইকোর উপরে ডপলারের শব্দ মডেলের উপরে ও আল্লাহ মনোয়ার জাহাদ খান লেকচার দিল কি বলবো আর এই সভ্যনাশ এর আগের দিন ফিরোজ একটা লেকচার দিছে মানে আপা এই ছেলেগুলা না কি জুয়েল এক একটা
খুবই ট্যালেন্টেড মহসিন
তো শুধু মহসিন বিশেষ করে আফজাল স্যারের পরে আপনি ওদিকে এদিকে আফজাল স্যারের পরে এই একটা অসাধারণ অর্গানাইজার আমাদের
তাই না না আবার সজলও খুব হচ্ছে
ওইটা মহসিনের পরে তৈরি হচ্ছে এখনই প্রশংসা করলেন না ও মাথা গরম হয়ে যাবে ও মহসিনের আদলে তৈরি হচ্ছে আরেকটা
তাই না
আমাদের কার্ডিওলজিতে আমরা খুব লাকি যে পরম্পরা অনেক ভালো ভালো একাডেমিক লোক তৈরি হচ্ছে
আমাদের হাসপাতালে অনেক আছে মাশাআল্লাহ লাইক কলিম আছে তৌফিক আছে তৌফিক তো অনেক সিনিয়র
হ্যাঁ এরা সুযোগ পেলে আরো ছাত্রদের বেলে ফ্লোরিশ করে যাবে
নেসার আছে হ্যাঁ স্মিতা টিটার একদম বাচ্চারাও আছে স্মিতা না
আমরা 100 ক্রস করতে শুরু করতে পারি ম্যাডাম 100 অলরেডি 109
এত তোমরা না
শুরু করে দাও
Assalamu alaikum, dear participants and faculties. Good evening. IPT is very much delighted honor. Professor Fazila-Tun-Nesa Malik, madam, is with us. She is extraordinary interventional cardiologist in Bangladesh, also home and abroad. He also one of the best presenter I ever seen around the globe. He's a nice presenter. He's one of the favorite presenter. We are waiting for his excellent talk today. The complication in Cathlab and management. She is the right person to speak on it. Professor Wadud sir, please tell something about it.
Assalamu alaikum and good evening everybody. Whenever we talk about a cardiotropy, we want to have good information in a very palatable way, and the presenter should talk it very clearly, precisely, and I should say in tune. Today, you will be delighted by the presentation of Professor Fazila-Tun-Nesa Malik, and the use of English language as a very communicative way. We can always learn from Fazila. And as Mohsin has been saying, as a very busy interventional cardiologist, as an administrator of a very busy Cathlab, she is very experienced and capable of talking the subject we are going to present today. Ladies and gentlemen, Professor Fazila-Tun-Nesa Malik. Appa, over to you.
So thank you so much, course directors, for your very kind words. So course directors, friends, colleagues, and students. It's indeed my privilege and honor to be here today, and I'll be talking about complications in the Cathlab and their management. Obviously, we do not want to have complications in the Cathlab. We want to have smooth sailing. But unfortunately, Cathlab complications do occur, and the idea is that we need to manage these complications effectively. So without further ado, let's start. I'm going to tell you some stories today. So this is a presentation which is mainly stories. I'm going to tell you stories today, and from these stories, let us discuss and learn. So the first story is a 63-year-old female patient. She came to us with non-ST segment elevation myocardial infarction. Her ejection fraction was 42%. And this is how her angiogram looked. So she had proximal LAD lesion 90 to 95%, which was involving the ostia of the LAD. And she had lesions in the RCA as well. The PCL procedure was uneventful, and we managed to fix both the LAD as well as the RCA. After doing the PCI, this patient was shifted to the post-cath ward with stable hemodynamics. 1 hour later, she suddenly complained of abdominal discomfort and very rapidly she developed hypotension followed by shock. The medical officer in the ward looked at the groin. It was absolutely fine. Check and echo was done. There's no pericardial effusion. ECG only shows sinus tachycardia, no other sign, and clinically the patient is paper white. With this scenario, she was shifted to the cath lab. Now we did her coronaries. The coronaries were fine, no stent thrombosis or anything, and the ECG also didn't show that. However, what we found is that there is this central jet of blood going to the retroperitoneum from the external iliac artery. And the amount of blood that is going, as you can appreciate, is so that she has gone into shock within a very short period of time. We have already started her on blood. She's getting blood transfusion, but she will not maintain. We need to do something with this jet of blood. So we need to stop it, otherwise we will not be able to save her. So with this in mind, what we did is we took a covered stent, a 7x18 covered stent, and we deployed it at 20 atmosphere pressure for 60 seconds. The perforation sealed up, the patient stabilized. She did require 3 units of blood, but however, we were very thankful to God that we were able to discharge her within 3 to 4 days. So this is the first story. So what do we learn here? We all know that compared to radial excess, femoral excess complications are more. And in fact, if you do a diagnostic angiogram, the incidence of complications from the femoral excess will be around 1.8, and for intervention procedures, it's around 4%. There can be minor complications like ecchymosis or bruising or a small hematoma. Major complications include hematoma, which requires blood transfusion, a retroperitoneal hemorrhage, which our patient suffered from. The patients can end with a pseudoaneurysm, an arteriovenous fistula, arterial dissection, thrombus, embolism. There can be vessel rupture even or limb ischemia. So the major complications, the list is quite long and it is quite daunting. So who are the patients who will be more at risk of vascular complications? So we will try to avoid complications in those patients, or by using another route, or being by extra careful when we do use the femoral route. So there are certain patient-related risk factors. A female patient, a patient who is elderly, a patient who has low body weight. On the other hand, a patient who is obese, a patient with small body mass index, a patient who is already suffering from peripheral vascular disease, a patient with CKD, or a patient with low platelet count. All these patients are at higher risk of developing femoral artery complications. So for these patients, maybe if possible, we should choose another route like the radial route. Or if we do use the femoral route, be extra careful. But there are certain procedure-related risk factors as well. Like if you, during the femoral puncture, do multiple punctures, then there is obviously more of a risk that you will end up with a hematoma or some other complications. That's why the first puncture should be the best puncture, and you should be able to get the vascular excess with that. Otherwise, also, if you use high doses or prolonged duration of anticoagulants, that's a risk factor. If the patient has previously been given thrombolytic agents, or we are using GP2P3 receptor blockers for a patient, we should be extra vigilant that that patient should not develop any femoral root excess. If we use larger sheath, or we are put a concomitant venous sheath, then that puts our patient at a higher risk. If we keep the catheter, the sheath for a prolonged time, or if a procedure is very complex and we do a very prolonged procedure, that also increases the risk of procedure-related complications. So for all these things, we have to be vigilant. Now, the incidence of retroperitoneal hemorrhage, thankfully, is not that high. It's around 0.1 to 0.5%, but that's also quite a big number, isn't it? And it occurs when we do a high femoral puncture. Now, how does the patient present? The patient is hypotensive. The retroperitoneal space is typically innervated by vagal nerve. So there might be bradycardia. Our patient had tachycardia. There can be back pain or groin pain, and our patient had abdominal pain. One important clue is that if you take the patient for fluoroscopy, you will see that the full bladder, it will be indented by the retroperitoneal hemorrhage. So how did we manage this patient? Obviously, you need to start blood immediately for our patient because she was already hypotensive and she was paper white. So we started blood. We sent the blood for hemoglobin estimation, and we did that serially to estimate how much blood she lost to give us an idea. We had to keep her for a prolonged bed rest. For this patient, we decrease the dose of her antiplatelets, like we gave her a single aspirin and a single clopidogrel. We didn't give, like it's customary to give at least two tablets of clopidogrel initially, but we didn't do that. But we didn't totally stop her anti-platelet agents because we had already fixed the leak with the covered agent. If the bleeding is severe, which happened for our patient, we need to identify it very, very promptly. Like maybe another 10-15 minutes, this patient, we might have lost her. So you have to be very, very quick for all cardiac complications. Being quick and efficient is the key. So you have to be very prompt. We identified it with angiography and treat it by a covered stent. You need to seal that. But if you cannot do that, or if the damage is such that it will not be taken care of by a covered stent, maybe really you might need surgical correction and evacuation. But obviously the risk will be very high for surgical correction. Now, one thing that we need to remember is that we always have to puncture our femoral artery, the common femoral artery, the part which lies just above the head of the femur. Why? Because this is the best part, the lumen is big, and also because after we remove the sheath, we can press our femoral artery over the head of the femur. So this will help us in proper hemostasis. And if we do a higher puncture, then what is the risk? The risk is that there might be retroperitoneal hemorrhage, which unfortunately happened for our patient. And if it's a too low down puncture, that we puncture below the bifurcation, then there are risk of arteriovenous malformation, a fistula, or a pseudoaneurysm, and also, of course, of hematoma. So proper positioning of the puncture is also very, very important. So we have to be very careful about this. So let's move to another case. This is a catheter-induced spasm. And the good thing about catheter-induced spasms is that they disappear after you give intracoronary GPL. However, when we are doing an angiogram, often if we see this kind of stenosis, we immediately jump to the conclusion that, oh God, this is a severe left main disease. But we should always remember that the DD of severe left main disease is maybe a catheter-induced spasm. So what is a catheter-induced spasm? A coronary artery spasm during PCI is a reversible narrowing of the lumen of the coronary artery. And it is caused by hyperresponsiveness of the tunica media smooth muscle. How does it occur? It can occur if we have manipulated our catheter a bit too much and our guide catheter has done a deep engagement. Or if we are passing stiff wires, it can also occur during balloon dilatation, it can occur during stent deployment. The good news, however, is that it will promptly respond to intracoronary GTN, and intracoronary nicorandil is also very effective. Now, the third case, this is a patient who was a 70-year-old gentleman, and he came to us with acute ST segment elevation myocardial infarction. His onset of pain had been 2 hours back. So we did his angiogram for primary PCI, and we saw that there was a significant stenosis in the proximal LAD. However, the good news was that there was no thrombus burden, and the onset of pain was only 2 hours of duration. So here what we decided that we were going to do direct stenting. And that is what is customary in most cath labs. When you are doing a primary PCI, obviously you try to do a direct stenting because you do not want to embolize the thrombus. So that's what we did, wired the vessel, took our stent, and did direct stenting. We did direct stenting with a 3/30 drug-eluting stent, and we went up to 14 atmospheric pressure. Just following the stent deployment, the patient started complaining of severe chest pain. He became hemodynamically unstable, and as you can appreciate, there is no reflow. So what is no reflow? Coronary no reflow is the inability to perfuse the myocardium after opening a previously occluded or stenosed epicardial coronary artery. The incidence of coronary no reflow is around 0.6 to 2%. So what are the clinical scenarios where you might see coronary no reflow? It can happen during primary PCI, as happened in our patient. It can also happen when we are doing very complex angioplastic procedures, like maybe a graft vessel PCI, and it can happen following rotablation. Now, there are two types of no reflow. One is reperfusion related no reflow, which happened for our patient with primary PCI, or it can be a primary no reflow where there was no actual thrombus burden initially. However, after the procedure, we noticed primary no reflow. The pathophysiology is multifactorial. It can happen due to cellular and interstitial edema, due to endothelial damage, due to platelet fibrin embolization, and due to vasospasm. And there is embolization of the platelet and the fibrin, and they go and they obstruct the microvasculature. And this leads to the no reflow phenomena. And only when more than 50% of the microvasculature has been obstructed by these platelet aggregates do you see no reflow phenomena. Now, the obvious solution for all complications is preventive. You don't want a complication. You should be aware that this complication can happen in this scenario, and you take adequate measures so that it doesn't happen. So to prevent no reflow, what do we do? Obviously, if you have a very severely degenerated saphenous vein graft, don't do that. Avoid that. Go and try to fix the native coronary artery. And if it is absolutely mandatory that you need to do a degenerated saphenous vein graft PCI, then it's a good idea to use a distal protection device while doing this. You should use adequate medications within the rota cocktail when you are doing rotablation. The birth to artery ratio should be around 0.6 or less. Then you should lower the rotational speed to around 1,40,000. And these are the steps you take for rotablation. And during primary PCI, obviously, if the patients are aware, then and there is a good ambulance service, then the minimization of the door to balloon time helps. If there's a huge thrombus burden, even now, with operator discretion, we do use manual thrombectomy, and we try to do direct stenting as we did in our patient, but still, even with direct stenting, he developed no reflow. And you can also pre-treat these patients where you suspect there may be no reflow with verapamil or adenosine. Now, there are certain drugs which are available which can help you to prevent to no reflow. And once no reflow develops, you also use these drugs. In our cath lab, we use adenosine and we use verapamil when the patient has bronchial asthma. And when a patient has hypotension as well as no reflow, we use adrenaline. The next complication that I'm going to discuss, now this is a rare and preventable coronary complication during PCI, and it is almost always iatrogenic, air embolism. And the incidence of air embolism is around 0.1 to 0.3%. Like this patient was, this was the start of a PCI procedure, as you can see, and suddenly a huge amount of air goes in and there is no forward flow of the dye. And the patient obviously is complaining of severe chest pain, his pressures have dropped and he is just moving around, wants to sit up. It's a bad situation. So obviously for air embolism also prevention, we have to be absolutely sure that there is no air in the syringe or in any of the tubings or anywhere before we inject the dye. We should inject the dye with a 45-degree angle of the syringe. We should also be careful when we are taking out hardware like wires, balloon, etc., because at that time also air might enter. So what do you do with air embolism? So our patient recovered, as you can see, and these are the steps that we do. First of all, you need to give the patient high flow oxygen. You give the patient atropine if there is bradycardia. You start vasopressors to raise the blood pressure. You can take wires and balloons, and you can dilate your balloon to break up the air. You can also do catheter aspiration to remove the air, and the treatment that we give for no reflow, the standard drugs like adenosine, verapamil, etc., these drugs are also used in air embolism. So let's go to our next case. And this is a patient who came to us for coronary angiogram. So he has good ejection fraction, 60%, and he's a 55-year-old male. So what happened is that during the coronary angiogram, there was iatrogenic dissection of the left main, and this led to the patient becoming hemodynamically unstable. So when the left main dissects, you have to fix it, otherwise your patient will collapse. So what we did is we immediately changed to a guide catheter. After changing to a guide catheter, we wired the vessel and we did direct stenting. We used a 4x12 drug-eluting stent, deployed it, did post-dilatation, and this was the final result. So what is a coronary artery dissection? A coronary artery dissection refers to a split or a tear in the wall of the artery, and this creates a flap which compresses or compromises the lumen of the artery, reducing blood flow. And dissection can be classified. So type A is when you give the dye, you can notice minor radiolucencies. However, once the dye is cleared up, the vessel does not show any radiolucency. This is type A. Type B is there are parallel tracts in the vessel, radiolucent areas. This is seen when you give the contrast. And once the contrast clears out, there is slight or no persistence after the dye has cleared up. In C type of dissection, there is an extraluminal cap, and this extraluminal cap persists even after the contrast has been removed. In type D, it is a spiral dissection. Type E is contains thrombus as well and may manifest as negative filling defects. And type F, that is where there is no forward flow, there is total occlusion of the vessel. So this is how dissections can present. So type A, B obviously do not require anything much to be done with them. But what are the risk factors for dissection? As we were saying, the catheter-induced dissection, we should always be careful of this, especially when certain type of catheters are being used, like an amplathe-shaped catheter. Other possible factors are when we do vigorous manipulations with our catheter, we are not gentle with our catheter. So being gentle with the hardware is absolutely mandatory. If the catheter is not coaxial and we give a vigorous contrast injection, this can also cause dissection. Deep intubation of the catheter inside the coronary artery can lead to dissection. If there is anomalous origin of the ostia and we are not gentle in our searching for the ostia and we do vigorous manipulation, that can give rise to dissection. And also, if the patient takes a sudden deep breath and the catheter goes into the vessel suddenly, it can cause a dissection. So all these can lead to dissection and we have to be very careful. And one rule of the thumb is never ever inject the dye unless the catheter is absolutely coaxial. How do we manage? For the vast majority of the patients, it is conservative management. However, if it's a major dissection, a spiral dissection, or the patient is complaining of chest pain and you think that yes, there is hemodynamic compromise is happening, you need to stent that dissection. For the vast majority of cases, the patient will respond with stenting nowadays. Sometimes when we are unable to stent the dissection, and when can that happen? If the vessel is heavily calcified or very tortuous and we cannot take the stent there, or we discover dissection but we are not able to rewire that dissected segment, in that case, in only 0.2% cases, we would need to send the patient for surgery. Now, this is a very long story that I would like to share with you. So this was, we presented this case in 2011. And we presented this case in the Lausanne complications course. So now, many of you are aware that there is a course in Lausanne, Switzerland. Professor Eric Eckhout organizes it. And in that 2011, I think there were 150 cases that were presented there. The number was submitted was even larger, but they chose 150 cases, and these were from like 68 countries. Okay, and this case in 2011, so Bangladesh, this case, because they reflect that they say the country is mentioned. So this case from Bangladesh, this case came second, and we had named this case a twist in the tail. Now the twist being that there is this RCA, right? And you can appreciate that the RC, okay, it looks a fairly easy lesion, but there was a twist. The twist was that there was this very large RV branch going from the RCA, and the RCA had two lesions, as you can appreciate, and the wire would just go into the RV branch. It was not going into the RCA. So what was done is that the proximal lesion was initially stented with the hope that if the proximal part gets stented, then we can easily negotiate our wire from the RV branch and go to the RCA proper. But due to the severity of the angle, we were unable to do that. So repeatedly trying, still we cannot go to the RCA proper. So what we did is we used the Crusade, which is a double lumen microcatheter, and we used the reverse wire technique. I won't go into the details of explaining how we did that because that is not the purpose of this talk. But with the reverse wire technique, we were able to wire the RC. That made us obviously very happy. So after wiring the RCA with a lot of techniques, etc., we are very happy with that. So we went on to stent the RCA, which was a fairly straightforward thing to do. And this was the final result. So now we have done our procedure and we need to pan to take our final shot. And you can see that our happiness suddenly turns into tears, right? You can see the perforation in the distal part of the PTA with the jet coming out from the distal part. So this is a wired perforation, like the wire has gone distally and it has caused a perforation. So the patient went into tamponade, so we immediately had to start pericardiocentesis. We kept the pigtail in situ and we were removing the blood. On the other end, what we did immediately also, we took export catheter, and with the help of the export catheter, we put in a coil, and we thus managed to seal the distal part of the PTA. The bleeding immediately stopped and the patient stabilized, as you can see. So this was the twist, like after such a lot of struggle, we managed to open the vessel, and then this had to happen. So one has to be very, very careful about the wires that one is using, and never ever allow the wire to go distally. And the safest thing is to make a knuckle with the wire. So a knuckled wire is a safe wire, but otherwise keep a watch on your wire. Now this is a larger vessel rupture that occurred. So this is a straightforward LAD, mid-LAD lesion, and mid-LAD are notorious for rupture. So be extra careful and don't go to high pressures with your stent in the mid-LAD. So here stenting was done after balloon predilatation, and as you can see, a full-blown rupture from the LAD. Now this patient is going to go into tamponade immediately. So what we did is we immediately inflated a balloon at the ruptured site, and this sealed the rupture. We also did pericardiocentesis at the same time. So you have to, when complications occur, the whole team occurs. So one person has inflated the balloon, the other has punctured the vessel and is doing pericardiocentesis. So once things were settled a bit, we took a deep breath and we knew that this rupture will not go away. If it's a small bleeding, that maybe if you inflate your balloon and keep it for like 40 seconds to a minute, sometimes a small perforation might see, but not this one. So what we did is we took a covered stent and we deployed our covered stent there. So the covered stent was 2.8 by 26. It was deployed at 16 atmosphere pressure. And this was the final result. So the patient was saved by, so you need to have these devices always in your cath lab, because catastrophe can happen anytime, even with a simple case. Like this mid-LAD, this is a 5 minutes job, right? But it ended up with a perforation. And so one good thing is always check after you've taken the shot, check always distally, proximally, everywhere, that everything is fine. And only after that, finish the procedure. So what are the risk factors for coronary artery perforation? Obviously, elderly patients are more at risk, female sex, tortuous and calcified vessels, and small caliber vessels. These are risk factors for perforation. Procedure-related certain factors are like if you oversize your balloon, then there is a risk of perforation. And especially if you are using a compliant or a semi-compliant balloon, this can cause rupture or perforation. So always use an NC balloon during PCI. If we go to very high pressure balloon inflation, that is a risk. Stenting of narrow or tapered vessels, stenting of lesions which have already been dissected and then you recrossed again. During a CTO, during a saphenous vein graft PCI, perforation can occur. During rotabation, it can occur. And also with the IVUS catheter, rupture or perforation can occur. longer. So when we are handling this kind of device, we have to be extra vigilant and extra careful. Now, if we classify coronary perforation, class 1 is a focal extraluminal crater without extravasation. Class 2 is that there is myocardial blush, and 3 is the frank contrast jetting out from the perforation. And in this case, the chances of getting a tamponade is more than 50%. And these are where you would need to intervene with some kind of device. So obviously, always with all complications, the message is prevention of coronary perforation is mandatory. How do we do that? So we should use low balloon to artery ratio, and we shouldn't go for very high predilation pressures. The stent, we should avoid high pressure initial inflation and oversizing in heavy calcification. And we should first deploy the stent at a nominal pressure. After we have deployed it, we should take a NC balloon and then post dilate the stent to its optimal size and properly oppose our struts. We should be very careful when we use stiff wires, and we should not allow these wires to go into small side branches, etc. So we should always keep an eye on our wire. Now, in the case where the wire caused the perforation, actually that was just a normal workhorse wire, but we should be extra careful with when we are using stiff wires. And when we are doing rotablation, we should try to keep the artery to Burr ratio lower than 0.8, ideally around 0.6. And angulated segments should be avoided during rotablation, like during LCX rotablation, there are more risk of perforation. How do we manage perforation? Obviously depends on the size of the perforation. If it's a small vessel or a distal vessel perforation, we do coil embolization. If it's a large vessel perforation, you need a covered stent. But if the covered stent is not adequate, there's still some jet coming out and you think that it warrants care, then you need to do surgical correction. Proper preparation of the coronary bed before taking a stent is absolutely mandatory. So especially if it's a heavily calcified or vessel, like in this heavily calcified and angulated vessel, the stent was attempted to be taken to its site for deployment. Unfortunately, the stent got dislodged. So proper predilatation, especially in vessels which are calcified, etc., needs to be done. So how did they recover the stent? The stent was recovered with the help of a snare. And so the snare was taken and the snare managed to get hold of the stent luckily that it had embolized down. So what are the strategies of managing a stent loss? If the stent luckily embolizes, goes to the leg or somewhere where it is safe distally, then maybe no treatment is required for peripherally embolized small stents. You can also deploy your embolized stent with the help of a balloon or a second stent. You can crush the stent into the wall with a second stent or balloon. You can try to retrieve your stent with a snare, which was done here. Sometimes removal of the stent is possible by twisting 2 wires. And the other thing is that you can inflate a small balloon distal to the embolized stent, and if that is the situation, and remove the whole system together. Sometimes during excessive manipulation of the wire may get broken, like while trying to open this CTO, excessive wire manipulation caused the wire to crack and break. So there is the wire lying in the LED. Now it needs to be removed. So what was done is a parallel wire was taken, and then a balloon was taken and inflated at the distal tip of the guide catheter. And the whole assembly was very gently pulled back and the whole assembly came out. So you have to just get the whole thing out. But at least the wire came out, and that is the best thing that happened, right? When we are stenting a vessel, especially when you are stenting the left vein, choose your stent wisely. A stent with a good radial stent is absolutely mandatory when you are doing a PCI of the left vein. Now, for this 60-year-old male patient who was undergoing PCI of the left vein, uh, this is his lesion, very tight ostial lesion, ostial left vein. So pre-dilatation was initially done because especially for left vein, you really need to prepare your bed well. After pre-dilatation, a 4x12 drug-eluting stent was taken and it was deployed. Post-dilatation was done. Immediately after stent deployment, things look fine, but suddenly we see that the stent is collapsing on itself and the patient starts getting a bit restless and uncomfortable. So what did we do? We immediately took another second stent and we deployed it at that site. So this is the sandwich technique. And the final result was this. So our patient settled down. So stent of the radial strength of your stent is very important in certain situations. Otherwise, it can give rise to unforeseen complications. And not only the radial strength, you also need a properly sized, proper length stent as well. Like in this severe ostial left main disease, after pre-dilatation, a 3.5 by 8 drug-eluting stent was taken, a small and short stent. Stent was deployed, post-dilatation done. Stent looked fine. The whole procedure is about to end. And then in the next shot, you see that the stent is not there in the left vein. We didn't have time to look for our runaway stent because the patient has started to get restless and start complaining of chest pain. So what we did is we took a second stent, a larger stent, a 4x15 drug-eluting stent this time. We deployed it, and after that, this was the final result. And after our patient had settled down, we started looking for the runaway stent, and we found that it was outside the catheter. So a snare was taken and the stent was removed. So when we do PCI, our stent should be absolutely of the proper size and also of the proper length. Sometimes during even a simple procedure, there may be unforeseen complications like abrupt occlusion of a branch. Like in this 60-year-old female patient, she came to us with non-ST segment elevation MI. And this is how our coronaries looked. So there was a dissecting lesion in the left vein, which was involving the origin of the LAD and the LCX. But to us, we felt that the LCX looked pretty decent, and our plan was that we would do a provisional stenting for the left vein. So we would try with a single stent strategy and see how it goes. So after proximal optimization with a single stent from the left main to the LAD, this is the final result, and we were quite happy with it. And as you can see, the LCX also looked fine. We thought this was the end of the procedure. But while the patient was being shifted from the in the cath lab, she was being shifted to the trolley. The ward boy and the sister, they noticed that she is starting to complain of chest pain. So they called us, and we went and we saw that yes, she is complaining of chest pain. So we immediately put her back on the cath lab immediately again, and she was sweating a bit. We did a check angiogram, and the check angiogram revealed that the LCX was getting almost subtotally occluded with thrombus, and there was TME1 flow. And the patient was very symptomatic. So we immediately started wiring the vessels. The patient became developed bradycardia, and the bradycardia was not responding to atropine. So we had to do temporary pacemaker as well. The LAD and the LCX were wired quickly. After wiring these vessels, what we did is we decided to do a tap technique. Obviously, that would be the easiest, and the angle also, fortunately, was suitable for a tap technique. So we opened the strut with a 2x15 balloon, And then we took a 2.75 by 18 drug-eluting stent and deployed it in the LCX with the tap technique. We did final kissing as is mandatory for double stent strategy, and this was the final result. Sometimes things can get even more messier. Like in this 50-year-old male, he had a very straightforward stenting of first the LAD, and then the LCS. So straightforward stenting of these two vessels, and the patient was sent to the post-cath ward with stable hemodynamics. Now, 2 hours after the procedure, the patient suddenly developed cardiac arrest in the post-cath ward. This was followed by respiratory arrest. Immediately CPR was started. The patient was intubated in the post-cath ward and taken to the cath lab. CPR was being continued and we did his check angiogram. So we put in a TPM as well. CPR is going on and this is how it looks. Total occlusion with thrombus, both of the LAD and the LCX. So we wired both vessels, obviously. We wired both vessels. We sent the blood to check for ACT. The ACT came low. We gave more bolus of heparin. We started the patient on GB2B3 receptor blockers. This case was actually like 10 years ago, so we didn't have bivalirudin at that time. We had bivalirudin for a bit, then it went off, right? So now what we did is we started repeated thrombus aspiration. So repeated thrombus aspiration both in the LAD and in the LCX was done. We gave the patient intracoronary GTN, and this intracoronary GTN sort of helped jumpstart the heart. This is one thing that helps, I think, like if your patient is really crashed, give the patient intracoronary adrenaline. Not GTN, I'm sorry. It was intracoronary adrenaline that we gave. So you take 1 ampoule of adrenaline and then you divide it into 20 parts. So 1/20th we give and then we go on increasing the dose. If you give the full ampoule of adrenaline, what happens is it suddenly shoots the pressure and then the pressure goes down. But if you sort of just gradually increase, it jumpstarts the heart and it really helps. So we gave the patient intracoronary adrenaline. So with the adrenaline, the patient sort of, as I said, the heart started moving and we did thrombus aspiration quite a bit and it sort of resolved. We later on changed the patient's, the patient was on clopidogrel and aspirin. This was quite a bit ago. So, this patient lived. This is the greatest thing. So actually, we all took a photo with him the day that he was discharged because it was such a miracle that he had survived. So prompt action. If emergencies happen, prompt effective action is also something that helps save our patients. And stent thrombosis can complicate around 2% of coronary interventional procedures. Obviously, stent thrombosis is associated with significant morbidity and mortality, and there is a high risk of myocardial infarction as well as death. What are the causes that can lead to stent thrombosis? There are certain stent factors, like if there is hypersensitivity to the drug coating or the polymer, and the patient can develop stent thrombosis. If there is incomplete endothelization, this was more common when we had first generation drug-eluting stents. Because of the permanent non-erodible polymer, the healing was delayed and often patients have incomplete endothelization. There may be certain factors in the stent design which can cause stent thrombosis. And another thing we need to remember is cover stents that we use for coronary artery rupture. These are also more prone to stent thrombosis. So these are stent factors. What are the patient factors? If the patient has presented to us with the acute coronary syndrome, there is a more chance that he may develop stent thrombosis. If the patient is diabetic, if the patient has chronic kidney disease, if the patient has poor ejection fraction, if the patient, for whatever reason, stops his dual antiplatelet prematurely, or if the patient has clopidogrel resistance or aspirin resistance, or the patient, this is just theory. No, nowadays no one does brachytherapy, but if the patient had brachytherapy, or the patient has malignancy, or if saphenous vein graft is treated, then patients can suffer stent thrombosis. Lesions also, like if the lesion is very, very long, if the lesion is very not narrow, if we do a complex PCI like a bifurcation lesion because you're putting in more metal mass there, or you open up a chronic total occlusion, we've already said saphenous vein grafts. These are lesion characteristics which make the chances of stent thrombosis more. And procedural factors. So in acute stent thrombosis, the procedural factors are also very important. Like if there is inadequate stent expansion, if there is incomplete stent apposition, we have to make sure with post dilatation that the stent struts are properly opposed to the vessel wall. If the stent struts are hanging there, this is a sure recipe for stent thrombosis. So if there is inadequate stent expansion, if there is incomplete stent apposition, if we deploy the stent in a necrotic core, or if the edge of the stent there is dissection, then all of these procedural factors can lead to stent thrombosis. So stent thrombosis can be a definite stent thrombosis, like in our case, because we showed that there was stent thrombosis with angiography, or if during autopsy stent thrombosis is found, then this is definite stent thrombosis. Otherwise, it is a probable stent thrombosis or a possible stent thrombosis. When stent thrombosis occurs within 30 days of the procedure, we call it early stent thrombosis. When it develops after 1 month, but within 1 year, we call it late stent thrombosis. And only if it crosses 1 year, we call it very late thrombosis. When we were dealing with the first generation drug-eluting stents, we were having a lot of, in cases, very late stent thrombosis. Because as I was saying, due to the permanent non-erodible polymer, these stents did not heal properly. So when there is acute stent thrombosis, this can be treated with balloon angioplasty, and we can do thrombus. Of course, we do thrombus suction. Repeat stenting is usually not done. What's the use of giving more metal mass? But if you see a definite dissection, and that dissection is causing the stent thrombosis, then you should obviously cover that dissection with a stent. Now, this is a late complication that we saw. So this case was done in another center, and this patient was admitted in our hospital because he was complaining of chest pain. And here, as you can see, there was this huge aneurysm was seen in the LCX and following PCI. So this happened a few months after PCI, this huge aneurysm. And obviously this aneurysm has the risk of bursting. And this is Dr. Ashok Datta's case that he treated very efficiently. So what did he do? He wired the vessel. After wiring the vessel, he had to seal the aneurysm. Now, how did he seal it? Because it's so large. So what he did is he did coiling of the vessel. So basically, he just coiled the vessel and put a stop to the flow. So the huge aneurysm, this was really, really large. I've never seen such a large aneurysm actually in my life. We had smaller aneurysms that we treated with cover stent, but this really is a very dramatic presentation. So what is a coronary aneurysm? A coronary aneurysm represents an abnormal dilatation of a coronary artery, and it is typically defined by the presence of an enlarged segment greater than 1.5 times the diameter of a normal adjacent segment. The incidence is around 1.5 to 5%. It most commonly affects the RCA, followed by the LAD, and lastly, it affects the LCX. So LCX Aneurysm is usually not that common. Etiology, it can be due to atherosclerotic degeneration, Kawasaki's disease, infection, polyarteritis nodosa, Takayasu's arteritis, connective tissue disorders like Marfan's or Ehlers-Danlos, and iatrogenic if there is deep vessel injury during PCI by a balloon or stent. And in the first generation drug-eluting stents, aneurysms were not uncommonly seen as well, where there was delayed healing. Gradually, the wall would get thin and you would see aneurysms there. Vast majority of aneurysms will be asymptomatic. However, we need to be aware of the complications like this aneurysm that we just saw was so huge that it would rupture anytime, right? It was massive enlargement, but rupture is a very rare complication. But patients with aneurysms may come with myocardial infarction due to distal embolization or in situ thrombus formation. How do we treat aneurysms? Along with DAPT, we give these patients oral anticoagulants. We can use covered stent for aneurysms. In this case, coil embolization was done. And if it's not amenable to these maneuvers, then surgery may be considered. Now, this is a very long history. This case we actually did as a live case. What happens, some patients have such long history, one thing happening after the another. And such was the case for this patient. So this was a 55-year-old gentleman, a migrant worker, and he had a primary PCI done in 2016 in Bangladesh to the RCA. He used to work in Kuwait, and in 2018 in Kuwait, he underwent CABG. A few months later, he developed chest pain. They did check angiogram, and they found that all his grafts had occluded. So what they did is they did left me to LAD PCI. They did put a stent in the LCX to OM. So they did PCI to the patient. And a few months later, he again developed chest pain. This time he was in Bangladesh, and we did his angiogram. And this is how it looked. So as you can appreciate, there is severe ISR in the left main, as well as there is a 99% lesion in the origin of the LCX. So the poor patient, he has already had CABG. After CABG, he has had a PCI, and there is ISR of the stent that was put in his left main, and there is also severe osteal lesion in the LCX. And this was actually a live case that we did. What we did is, that's a very long procedure, we won't show that, but we did DK crush, okay? And the DK crush result was very satisfactory, and we could see with OCT that it was, the result was satisfactory. This was the final shot, but one of the panelists right at the end said that he was concerned with the osteo of the LCX, so he asked us to do an IVUS at the very last moment. We also did an IVUS, and the IVUS also showed that all the struts were open and the bifurcation was fine. So this is just to illustrate that restenosis is something that can come and haunt us anytime, even not just right at the cath lab, but 6 months down the road from the cath lab. And instant restenosis is something that we don't really look forward to. So what is this? Well, instant restenosis is an angiographic, it's a definition, it's an angiographic definition, and it means that there is recurrent diameter stenosis of more than 50% in the stent segment or at its edges. So instant restenosis can happen inside the stent or even within 5 millimeters of the stent. And depending on where it is, it can be focal or it can be very proliferative. So obviously the proliferative ones are the ones where the patient gets symptomatic. So there are factors responsible for instant restenosis. One is patient related, obviously, and again, it's elderly patients, female patients, patients with diabetes mellitus, or some genetic predisposition that makes these patients prone to instant restenosis. It can be lesion related, like if the lesion is very long and diffuse and we've used multiple stents, or in case of osteal lesions, and in case of bifurcations. In very narrow caliber blood vessels also, the chances of instantary stenosis is higher, and in multivessel coronary artery disease where you've used multiple stents. Procedure related, the stent type, obviously in bare metal stents, you get more instant restenosis than you get in drug-eluting stents. The length of the stents, if it's multiple stents have been put back to back, then there is always chance that there might be instant restenosis. If there is stent overlap, multiple stents with overlap, at the overlap site you might get instant restenosis. If you do not expand your stent properly, there's stent under expansion, then this can lead to instant restenosis. Also, if a patient had a history of instant restenosis to one vessel, you should remember this when you go and put another stent in another vessel. There is always a chance that he will also develop instant restenosis in that vessel as well. So, clinical presentation, most instant restenosis patients will be asymptomatic. Some who might present with stable angina, but also if there is rupture of the new atherosclerotic plaque, the patient may come with acute coronary syndrome. So if the patient is symptomatic with stable angina, what can we do for that patient? We can do POBA. We can use a cutting or a scoring balloon at the site of instant stenosis. We can use a drug-coated balloon there, but the first three, these we can do only if the stenosis is inside the stent. It has not spread 5 millimeters on the either side. If the stent is severely underexpanded or is calcified, then we can do rotablation, just ablate the stent and then put a new stent. And if the instant restenosis is very extensive and extends there is peristent restenosis as well, extending outside of the stent, then maybe we can do pre-dilatation and then put in another drug-eluting stent at that site. So in conclusion, I've come to the end of my discussion. The message that I want to tell you is that obviously prevention is better than cure. So try to avoid complications in the cath lab by always being vigilant and very watchful during a procedure. Constantly monitor your patient during the procedure as well as afterwards for early detection of any complications that may arise inadvertently. The cath lab needs to be always fully equipped with all items that might be required should an emergency arise. And when the emergency arises, the team needs to be ready and well prepared to deal efficiently and effectively with any complications. And as I always say, the strength of Heart Foundation is our cath lab team, and from the entire team, there were some cases which were contributed by some of who are sitting here. So thank you for being such an excellent team and for being there always. Whenever a complication arises, the whole team goes there and we solve that problem. So thank you for being the best team ever. And with that, I would like to say thank you to all of you for being such patient listeners. So thank you.
Thank you, madam. Thank you. Thank you, Professor Fazila-Tun-Nesa. What a nice case-based and practical demonstration lecture class. We are not only participants, we are faculty learn how to present a lecture with a case-based discussion. So we are really delighted from your lecture. Sir, please tell something. Sir.
I have been already forecasting that we will have a very pleasurable experience. My reasoning was very much correct. It was a very wonderful presentation for Dilapa, and with such beautiful case-based manifestation of what you are actually saying and how to tackle these problems. It was really wonderful. I have one question before the start. Appa, you should remain unmuted. Unmute yourself. Yeah. Appa, one question is that in case of left main stenosis, you were saying the proper radial strength should be taken into account while we are choosing a stent. In your experience, which stent actually you are using in your cath lab mostly for this purpose?
No, actually, you see, first of all, I would say that most of the drug-eluting stents nowadays that are available in the market are very effective, and it is operator's choice as well. Like in our hospital, different operators use different stents. And in different situations might choose a different stent. We have more than 2,000 cases of left main PCI that we have done in our hospital. And in 50% of the cases, we used a zotulimus eluting stent. And in I think 28 or 29%, it was an everolimus eluting stent, and the rest was other like biolimus, sirolimus. So the choice depends, but one thing that the operator should do is use a stent that you are comfortable with, that you know, like you know that this stent has great radial strength, you know that it will give you great side branch accessibility, you know that it will go through tortuous vessels. So like personally, I also have my own stent that I prefer. Everyone has their own stent, but whatever stent you're using, try to use a stent that is FDA approved. Definitely, when you're doing a left main PCI, do not compromise on that, and also use a stent that you are comfortable with.
Thank you, Professor Dr. Mamunur Sidar bhai. Professor Mamunur Sidar.
Yes.
Professor Mamunur Sidar.
Thank you, first of all, Professor Fazila Appa, for nice deliberation and highly informative the lecture, as always. And I want to say that we are always enjoying her lecture, and with, in this case, all the complication of the Cathlab is demonstrated with the case by demonstration. One thing I want to share that regarding the stent thrombosis, in one case, when the patient already had a stent, one stent in the vessels, then sometimes I have experienced that one of my patients having the left LED stenting 4 or 5 years back, 5 years after he came with the chest pain and diagnosis non-STMI with LCX stenosis. And I am trying to negotiate the wire. It is a little bit CPO type and taking time. In this time, patient suddenly chest pain. And fortunately, we are working in the LCX and just giving the shot, then we see the stent in the LED is a thrombus burden. And then we give wire and the thrombus. By this time, patient's cardiac arrest was developed and CPR was going on. And this time, after wiring, just thrombosuction, we can establish the flow. And again, we came to the LCX and doing the PCI. And in this case, what is your opinion that should we more cautious have any patient with the already in one stent in vessels and stenting in another vessels? Any caution should be taken regarding the anticoagulation or something?
Well, congratulations on handling a very difficult situation. Your patient was safe, because when you do complex cases, complications might arise, but to bring the patient safely is our aim, right? So you manage that, and congratulations for that. What I feel here is that this is a common thing that can happen with CTOs. When we are engrossed in opening one CTO, sometimes we do not look at the ACT. So obviously, when we do a normal case, maybe we can finish it in 10-15 times, but when 10-15 minutes, right? But when we are opening up a CTO, we get so engrossed, 30 minutes, 40 minutes is going, we do not check the ACT. So when CTO is being done, I think one of the team members, like in our Cathlab, what we have some sisters who will come and say, 30 minutes have gone, should I go and check the ACT now? So if the ACT were checked, maybe the procedure was so prolonged that the ACT came down and there was thrombus in your LAT was created. Also, another thing is sometimes, thrombus may get, created in the catheter itself. So during a prolonged procedure, thrombus might even form in the catheter, maybe in the tip of the catheter. And during the procedure, someone gives a dye and the thrombus will obviously go into the LAD. So during prolonged procedures, I think you need to, have someone who checks the ACT a few times. Your procedure, you said the LCX was a CTO, and obviously time was prolonged. So maybe due to that prolonged time, the ACT went down and thrombus was formed either in situ in the LAD or inside the catheter.
May I put in something, Appa? As you were saying,
already one stent was previously in the LAD. This
I
may
know,
contribute
I
more risky. Any one stent already in the stent. Should we more cautious regarding this case?
But you placed the stent a few years back. It wasn't done that time. Na? You said that that stent, so that stent was already endothelized most likely. If it is a second and third generation stent, most likely it was already endothelized. If it is a first generation stent, then we have that issue. But it's always, a patient who has already had PCI, obviously has a lot of atherosclerotic burden.
Okay.
So you wanted to say something?
I think most of us has the same experience, because almost all of these cases, either the ACT was not taken or the sister forgot to give the heparin. It has been said
that is a very
intervention should give the heparin himself or herself. That's a very important thing.
I think that's very important.
Another thing is that whenever the procedure crosses 1 hour, check the ACT again. Make a rule in your Cathlab. That really helps. We have some scary situation like that, and once upon a time, we do have some really problem with fake heparin as well.
Thank you, sir. In the COVID pandemic era, we are encouraged to see lots of participants, sir, 180 participants.
So we are also
Professor Muhammad Jalaluddin sir with us.
Jala sir
with us. Monijuman sir, Kaisar Rasulullah Khan, Dr. Povik Das.
Abudin bhai, Khaled bhai, সবাই আছে কবিতা।
সবাই আসসালামু আলাইকুম, থ্যাংক ইউ সো মাচ সবাই যে আসছেন, তাই না? এটা তো কোভিডের একটা সৌভাগ্য যে আমরা সবাই একসাথে দেখা হচ্ছে, তাই না? ইউজুয়ালি তো শুধু বিয়ে শাদিতে বা কনফারেন্সে দেখা, এখন বাসায় বসে দেখা হচ্ছে। আর ওয়াদুদিটা অ্যারেঞ্জ করছো, তো ওয়াদুদির ধন্যবাদ, আর মহসিনের ধন্যবাদ, আর সবাই যে কষ্ট করে আসছেন দাওতে, সেই জন্য সবাইরে ধন্যবাদ, আর সবাই আসসালামু আলাইকুম।
Jalal sir, could you tell something, sir? What's the Jalal sir?
আপনি আনমিউট করেন স্যার। জালাল স্যার আপনি আনমিউট করেন। ঠিক আছে। Yes.
Are you hearing me? Are you hearing me?
Yes sir. Yes sir. Assalamu alaikum sir.
Assalamu alaikum to everybody. I am very happy today that Fazila has become mature. Fazila in the beginning was telling to another boy that this bacha has become a mature one now. Today I am telling that I was professor of cardiology in NICVT. Fazila was my registrar. At that time, I was doing some angiogram, pacemaker, but not any intervention. At that time, intervention was not started in our country. Only that she was assisting me in pacemaker and simple angiogram. Now, I am so happy that Bacha May has become mature, doing so many angiogram, angioplasty, and complicated angioplasty, and also facing the complications and treating those complications very successfully. I am so happy.
Sir, thank you, sir. Sir, you were a teacher, sir.
Fazila sir,
বাচ্চা না স্যার, ফজিলার বাচ্চা কার্ডিওলজিস্ট, কিন্তু ফজিলার বাচ্চা কিন্তু কার্ডিওলজিস্ট।
Yes, but bacha
স্যারের চোখে বাচ্চা সবাই।
না স্যার, স্যার আমাদের সবাই স্যারের সাথে তো আমরা বেশিরভাগ এখানে যারা দেখা যাচ্ছে সবাই স্যারের সাথে কাজ করছি, তাই না? সবাই স্যার আপনি আমাদের সবাইকে ভালো শিখিয়েছেন স্যার, এইটা হলো আসল কথা স্যার, আপনি ভালো টিচার ছিলেন স্যার। স্যার এটাই হলো, থ্যাংক ইউ স্যার।
Another thing, the father of Professor Fazila-Tun-Nesa, Professor Brigadier Abdul Malik, was my teacher while I was in PG hospital. Later on, I am the first man of his students to join as his assistant in newly started NICVD in 1979. I was very happy and I was fortunate to work with him. That I also became the director of the institute before my writing. It was my fortunate, and I feel very much gratitude to my Professor Brigadier Abdul Malik. And later on, he was my teacher, and I was the teacher of his daughter. I am the intermediate person.
Thank you, sir.
Yes, sir.
Thank you, sir.
I'm very happy that Dr. Fazila-Tun-Nesa faced so many complications, and also because he was doing so many angiogram and angioplasties. Naturally, every cardiologist who are doing more cases, they will face more complications. And I think, and he has shown quite a good number of cases of complication, what he has managed very successfully. Thank you, Professor Fazila-Tun-Nesa.
Thank you, sir.
Professor Rahiduzzaman, sir. Sir,
Yeah,
he also evidence
Nice to
of
see.
complications. Please, sir.
nice to see a lot of face. Actually এটা বিয়ের দাওয়াতেও বোধহয় এরকম দেখাশোনা
না
হয়।
তো গল্প হয় না।
পার্থক্য একটা, এখানে কোনো খাওয়া দাওয়া নাই।
না, আসসালামু আলাইকুম স্যার।
জি, আসসালামু আলাইকুম। নাইস ফজিলা, অ্যাকচুয়ালি আমরা বাইরে যে সমস্ত নাইটমেয়ার দেখি, অলমোস্ট শি কভার almost everything
almost
possible
everything.
complication.
Almost.
Thank you, Fazila. A unique case-based discussion of almost all the cases within short possible time of 1 hour.
Thank you.
Basically, there is nothing new to tackle all these things. We know it. How to tackle, we also know it. But because of ignorance and sometimes late identification of complication, sometimes we've lost the patient. So my simple word is just, no case is simple. Think every case can land up with complication. It's not that ask your junior to do the case and you will be just outside the hospital or outside the cath lab. It may land up with a complication when you will be in time to handle those cases. So first thing, every case should be considered as a potential complicated case. Second is the care should be taken from the puncture to end of the lab, and also first 24 hours after the procedure in CCU for hemodynamic monitoring. If not yourself, the junior should look for certain things that we know, so that we can quickly identify the probable complication. The Fazila showed two interesting cases and is almost deadly situation. One is the left and complete occlusion with LAD and RCA. If it was not been done properly, proper means that within 5 minutes. And other one was the retroperitonal hematoma. These two things, if you don't identify in time, whatever you do, the result may not be good, as I'm sure. The same thing happened to many of us. Some survived, some didn't survive. If you compare these things, why it happened is simply because of late identification of the complication. And there should be a very good teamwork, because if in your cath lab, if everybody is attention and focus on the case, and if there is no panic, where the most problem arises, the operator shout right and left and everybody is scared to handle. Be quiet, and there should be team effort. If necessary, ask your colleague, I should say not junior, ask your colleague to come and wash. It will give a lot of relief of your stress. Mere presence of your colleague in the lab is enough to give a good amount of mental strength to handle the case. Third one is that you should also involve, at least inform the surgical team, surgery, and you should be innovative. So these are small things. If you keep in mind, you can avoid complication, and even if it happen, you can deal complication right time with right devices. This, to me, I think this is in a nutshell I can say.
Thank you, sir. Before going to the panelist and ask one of the faculties from the Nepal, Dr. Shumir Paudel. Please ask your question. Put your question. Dr. Shumir Paudel from Nepal. You please unmute. Dr. Shumir.
Yeah.
Can you hear me now?
Yeah, we are here.
Thank you, ma'am, for your nice presentation. My question is, when there is aneurysm, coronary artery aneurysm in a big vessel, then coiling the coronary aneurysm, coronary artery aneurysm, has a great risk of developing ischemia. Then how can you tackle that? If the vessel is very small, there is no problem. It's all right. But for a big vessel, as you showed in your slides, how do you manage that?
Actually, this for large vessels, you should not be routinely coiling, right? But the case that I showed, that was unique. You can appreciate that. There was this huge, giant aneurysm, right? And it was sort of occluding the whole vessel anyway. The LCX was practically not serving any purpose for that patient due to that huge, giant aneurysm. And the aneurysm was of such a size that it could rupture any minute. And if it ruptures, it would, we all understand, be completely a catastrophe for the patient. It would lead to a fatality. So here the operator had no option but to call that aneurysm because it was not serving any purpose. But as you have rightly said, for a large vessel, we would normally never coil a large vessel, because if we coil a large vessel, obviously we were basically causing obstruction to the flow of blood to a huge amount of myocardium. And if that place is not well collateralized, there will be definitely a lot of problem for the patient. So normally in a large vessel, we do not use coils. In this unique situation, coil was used because the aneurysm was of such a magnitude that it had to be closed. And also, it is my understanding that this patient had a lot of comorbidity, which was making him an unsuitable candidate for surgery as well. So he had been already refused surgery. So the only option for this patient was the coiling.
Thank you, ma'am.
In general, when there is a large aneurysm involving a big vessel, and that heart is dependent on the flow of that vessel, the choice of is surgery.
Yes. Yeah, absolutely. The choice is surgery. But for this patient...
it was very good. Ashok has done a very good job. Yes. And that was a wise decision, actually.
Doctor, one of the COVID fighter is here, Dr. Kaisar Nasrullah Khan. He's come back with us after COVID fighting. Dr. Kaisar Nasrullah Khan, do you hear me, Kaisar bhai?
We are all COVID fighter. He is a COVID star. He survived COVID.
Yeah, he is a COVID star. Oh, I think so. Kaisar bhai, do you hear me?
Kaisar, unmute yourself.
I think he's...
And he's not yet present.
Dr. Khalid Mohsin. Yeah.
Okay. Thank you, madam. It was really a superhuman effort to cover so many complications with illustration in 1 hour time. You started from the puncture to the wear tip. So actually, the perforation of the coronary artery is probably the most dreadful complication in the cath lab. So I want to have your expert opinion regarding the partial reversal of anticoagulation and use of a second puncture and a second guide catheter to
so
put a covered.
What's
your opinion regarding LS3 perforation dealing? Actually, just
right. So very good question, and thank you, Khalid. So As usual, Khalid is the academician and he is asked a real academic question. So thank you for the question. And it's true that in certain cases, the ping pong technique is used, and that is very effective. Like if you have a huge puncture and you want to safeguard it as well. So what is done is from the antegrade part, you pass a balloon and you inflate that. So you have already sealed the perforation. But the perforation is of such a magnitude that when you deflate and remove it and then take your covered stent, you feel that you do not have enough time to do that. Removing the balloon and then putting the covered stent, your patient will collapse. So what you do, you keep your balloon inflated at that side, and from the other side, you do another puncture. You take another guide catheter, and through that guide catheter, you wire your vessel. After wiring, you just deflate for a second and let your wire pass distally. You inflate your balloon again. Now, through this other catheter, you take your covered stent, and you take your covered stent as near as possible. You deflate your balloon, pull it back, put the covered stent, and you're set. Thank God and touch wood, I have not as yet needed to do this in my lifetime, and I do not want to do it. But this is called the ping pong technique. And this, and I would also like to mention here that all these, the sequence that I have covered of complications, the tables and charts that I have used, these were all taken from the NHF manual for intervention. And this NHF manual of intervention, the complications chapter was written by a very talented doctor, Dr. Kolimuddin. And in that chapter, he describes the ping pong technique as well. So if anyone wants to have a look at this
regarding
reversal of heparin, I don't know, I'm very hesitant about reversing heparin. I will check the ACT,
Madam,
I usually do not want to reverse the heparin because I don't want to end up. So I've got a perforation and then I might end up with a stent thrombosis. So I check the ACT. We in our hospital we check the ACT, but if it is we usually do not use protamine.
Kaiser, do you hear me? Kaiser, do you hear me? Kaiser, do you hear me? Okay, Dr. Virat, do you hear me? He's from Nepal. He's lots of questions he asked in the chat box. Dr. Virat, you ask your question now.
Yes, sir. Thank you, ma'am, for your brilliant presentation. There are a few questions that I'd like to ask here. So regarding the coronary dissection, ma'am, so how do we know when to leave it alone and manage it conservatively? Are there any criteria? That is the first question.
So yes, for dissections like anything else, you look at your patient, right? Your patient is stable. There is no chest pain. Hemodynamically, no change, no ECG changes. And it's just, like type A or B type of thing in the angiography. So you can leave it. Like you've placed a stent and at the edge of the stent, there is this slight type A type of dissection. Maybe you can leave it. But where is that dissection as well? Is it in but if it is in a major vessel like which happened in the left main, so you know that you cannot afford to leave it, right? So symptoms is one thing that is very important. How is your patient doing? Where is the dissection? And what type of dissection is it? If it's totally occluding your vessel, of course you need to do something. If it is a spiral dissection, you need to do something. If it's in the left main, you need to do something. So it will vary from situation to situation.
Thank you, ma'am.
Actually, one of the things to do, if you suspect there is a slight slow fluid, some edge dissection, just wait there in the cath lab. 5 minutes, 7 minutes, and see again, checking whether the flow is quite all right. If it settle down, I think Appa, as Appa was saying, they can leave it alone.
Wadud is quite right. Give some time to follow up the patient in the cath lab. If patient is not hemodynamically unstable, then we can wait for some time. If it is grade 2, up to grade 2, then we can use the balloon for some time. It's a pressure up to 15, 20 or 25 minutes up to pressure. And then patient, if it is stable, there's no need for the covert stent or something others.
That's a great suggestion also. So you can do a balloon inflation and then at least keep it for 45 seconds, 1 minute, or as long as your patient tolerates, deflate it, see how the antegrade flow is. If it is, in many instances, a small dissection will see by itself. That's a great suggestion that Caesar just gave us now about doing balloon inflation at the site of
Thank you, ma'am.
Thank you.
Other question.
One more question, ma'am.
Yeah.
In cases of perforation, ma'am, how long do we inflate the balloon before deflating, and at what pressure do we inflate it? And do we inflate at the site of perforation or proximal to it? And if there is no extra vegetation after deflation of balloon, do we need to stent with a cover stent in all the cases?
Okay, so Caesar has already answered the question, right? That if you can do a balloon inflation and you wait and you see that it has sealed, then you can just leave it like that, right? It's sealed and you wait for some more minutes, you check with your ACT, everything is settled, then touch wood, okay, you're in safe hands and you don't need to do anything, you don't need a covered stent. That is a very nice situation that can happen. But
actually, his question was about the cycle. How many minutes you want to inflate, then for how much time?
So that absolutely depends on how long your patient tolerates. Like if the patient is tolerating prolonged balloon inflations, you will try to inflate your balloon to the maximum tolerance level of your patient. So if your patient is tolerating, fine, keep it inflated and then do it. But if he's not tolerating, then you will have to deflate and again inflate very. So it will vary. There is no, like, I would feel a hard and fast rule that okay, I can do it for 1 minute or 2 minutes or 45 seconds. It depends and it will vary from patient to patient. But obviously, you want to prolong the time of your inflation. So
actually, for a case of CTO, which is getting a retrograde feeling from the other vessel, other side, you can actually go for prolonged stenting because it was already was closed before.
Wadud, can I may take one?
Yeah, please.
Thank you, madam, for nice presentation. I like to add, madam, is there any rule to inflation of the balloon for 3 times and see the dye, and if it is not improved at all, then go to cover stent?
Actually, almost. Thank you for your question, but I personally am not. I'm not aware of this, but if you know about it, please actually do tell us. So is there something like this in the 3 cycles or something? I mean, have you read some?
There is no like that hard and fast rule. Actually, I have
30 minutes.
I inflated up to 25 minutes. Patient afford it, and I inflated up to 25 minutes. And I do not know about the Omol, what is saying that is 3 cycle, or I do not know that is this.
That is 30 minutes we can wait and then see if
perforation, yeah.
So after 30 minutes, if it seals, that is very good news, right? So we can, and sometimes like the LAD case, the perforation was so huge, even if you sat there for the whole day, it would not seal, right? So also the size of the perforation, first visual impression also gives us an idea. Sometimes also, this will seal, this most likely will not be sealing. So for that which will not seal, to safeguard the patient maybe, and if you have the cover stent at hand, I think that we should just go and use it. Just to,
Thank you, sir. Dr. Kaisar with us. Kaisar bhai, do you hear me?
Yeah, I can hear you loud and clear.
Alhamdulillah, with us. Alhamdulillah.
So welcome back, Kasser. Kasser, we prayed for you. So I'm very happy to see you here today. How are you doing? Feeling better now?
Thanks, ma'am. Thanks, ma'am. I've already recovered.
Okay, so.
Hello. Kasser.
Any questions?
Kasser, আবার out হয়ে গেল দেখি।
ওয়াজুদ ওকে বের হয়ে আবার ঢুকতে বল।
Dr. Abdullah Mamun, do you any question? Doctor, I have a question from the participant. Abdullah Mamun, please ask your question.
Assalamu alaikum, ma'am. I have a question. In case of coronary perforation, is that iatrogenic fat embolization done to manage that perforation? Is it done in our country?
Well, actually, when we were starting our CTO program, we used to have Japanese operators come very often, especially a very close friend of ours, Dr. Shumit Shuzi. So he would come and he had this, box. So he's a CTO operator. So he had this box, and in this box, he had all kinds of gadgets with which to close things. And we've learned such a lot from him. So he used to use this fact. I personally have not used it, but he did use it once in a small perforation. But I personally don't have any experience of using that. So, I mean, a coil is a lot easier to put, right? So if a small vessel perforation occurs, I would say go for a coil if you have it in your shell.
Okay, Dr. Ashok Datta with us. Dr. Ashok Datta with us. He raised hand, I think some question from raised hand. Yes, yeah.
Ashok, unmute. Mute.
Unmute.
Ashok, you have to unmute. Ashok, we are not listening. You have to unmute yourself.
Yeah, I mean, okay.
শুনতে পাচ্ছি?
এখন শুনতে পাচ্ছি, এখন।
ম্যাডাম, থ্যাংক ইউ ভেরি মাচ।
তোমার কেস দেখাইছি। তোমার বলন।
আর জালাল স্যার আছেন, অদুত স্যার আছেন, মহসিন, সবাইকে আমার সালাম। It is an excellent program. I raise my hand to thank everybody.
Ashok, you are losing your glamour. Please color your hair.
Thank you.
Mohsin, is there any question? Let me see. For port, one side larger balloon is used. Can we use semi-compliant or compliant balloon for port? If used, at how much pressure maximally can be post-dilated?
So there's a school of thought, especially for the left main disease. For port report, they use semi-compliant balloon because they want to be absolutely sure that the struts are properly opposed to the wall. So a school of thought, they propose that especially for left main, when you are doing port report, use semi-compliant balloon.
Yes.
So, and the size and the pressure depends upon the operator, right? So you have to go, like with the NC balloon, you have to go to a very high pressure. With the semi-compliant, it's a bit less than that, right? So it will vary according to your rated burst pressure.
Pamichal bhai, apnar opinion?
No, thank you. In fact, in my shelf, rarely we use any semi-compliant balloon. Most of the balloon is non-compliant balloon.
We also use the NC balloon. Amra should NC use for it.
So that's why rarely we will find something non-compliant balloon for expand. There is advantage of non-compliant balloon. If you want to expand a vessel, it is really more than 4.5, more than 4. You are taking a 3.5 balloon. You don't have any other things. If you inflate it, there is a chance it will expand it. But I think the right size, if you take right size balloon, correspond with the size of the vessel, go up to 20 atmosphere, nothing will happen. And all you need to just measure the actual size of the vessel. If left main, you can measure it by IVAS. If it is more than 4.5, take a 4.5 balloon. Because 3.5 or 4 millimeter balloon, even if it is non-compliant, it will not go too high. Maybe 0.2 to 0.3 it can increase. So if it is 4.5, take a non-compliant 4.5 balloon and go to nominal if necessary. You can go up to the 20 atmosphere. That's my practice. Because I don't have any semi-compliant balloon in my shell.
We also use NSIM only.
Mohammed sir, can you
what question?
In balloon, can you use? You start, and madam also.
Sorry.
You start in high pressure, very high pressure, super pressure.
Opium balloon. Opium. No. I have not used this. No. But the thing is that yes, there is a very few occasion you need to crack the lesion, very fibrocalcific lesion with a very high pressure. But I can say most of the calcific lesion, if not severe circumferential calcium, can be handled with what we have got Corflex or we got double wire technique. Go to with a 20 atmosphere that can crack the lesion.
Mounjam sir, you are telling that the NC balloon should be the size of the stent. Like that is, if the stent diameter is 4, then NC balloon should take the 4. In case of some stent, in third generation stent, which can be more inflatable. That is, if it is size is 4, then it can be inflated up to the 4.5 or 5. Then we can take the NC balloon is more bigger size.
Actually, stent or vessel size, that's the important thing.
Actually, you should not cross the vessel size. Then there is a chance of perforation. You must be careful about, don't be more than the vessel size. If you fit non-compliance, advantage is that even if you go up to its 20 atmosphere, it will not expand to that, hardly it will go 4.1. So if you go in a nominal, so it will be 4 millimeter. So that is the advantage of non-compliant balloon. Definitely, usually we take these things for left main, basically. But it's the mid LAD, and this thing is a very, you must be careful to avoid complication like rupture or perforation.
From Sleep Medical College, the regular participants in our session.
Thank you very much, ma'am, for your excellent deliberation. It was so many brilliant and so case-based that I learned a lot. That as if I am a many year student and you are telling me is in third part in MD student like that. I am listening like a student in third.
Thank you so much.
Ma'am. Thank you very much for your excellent presentation. It was so excellent that I commented in several ways in Facebook and also in your
thank you so much.
Site box also. Thanks, madam.
Very kind.
Thank you. Dr. Arif, do you hear me? Lots of questions in the chat. Please read the question because it is a program for participants. Okay.
Right, sir. Thank you. Thank you, madam, for your excellent presentation and elaborate presentation. There are lots of questions. Most of the questions are related to perforation. And there was also in the meantime the huge discussion on perforation, and a few questions are already discussed. So I am mentioning the relevant question. The one question was long-acting nitroglycerin tablet before going to Cathlab. Does it prevent artery spasm? Long-acting nitroglycerin tablet before going to Cathlab. Does it prevent coronary spasm?
Well, actually, I do not have much experience with this because we do not routinely give any patient any long-acting nitrates before we go to the cath lab. However, during the PCI procedure, we always keep intracoronary nitrate at hand. So we go on giving that if the pressure permits. So if the pressure is good, we go on giving intracoronary nitrates depending on the pressure. If the pressure is very good, we give 100 mics of intracoronary nitrates on a regular basis. If the pressure is low, it may be 25 or 50 micrograms that we give, but we give intracoronary nitrates during the procedure.
Thank you, madam.
Give oral.
I have not seen any document or any report that giving long-acting nitrate before a procedure actually prevents spasm. I haven't seen anything like that. Abdul sir is here. Sir, কি কিছু বলতে পারবেন? Long-acting nitrate, Cathlab-এর প্রসিডিউরের আগে দিলে পরে long-acting, তার মানে oral nitrate, সেটা দেওয়ায় এই যে স্পাজম বন্ধ করা যায় কিনা? আমি এটা কখনো দেখিনি।
No, there is no recommendation. No, sorry, there is no recommendation like that. We have to give the nitroglycerin. We have to give the injection.
Coronary.
Bolus injection, injection nitrate in bolus. And usually what we have to do, we have to always assess the vessel size and also the lesion characteristics. We have to give the nitrate. And sometimes there is spasm that can be that can mislead. And if you get a nitroglycerin, the spasm will relieve. On the other hand, if we see the exact size of the vessel, it is better to give the nitroglycerin. But we are not using it frequently, but it has to get the nitroglycerin in bolus doses, not in oral. There is no recommendation like that. I don't know. I have any experience for that. Sorry for that.
Thank you, sir. In case of perforation, what are the situation we have to go for auto transfusion of blood?
I personally, we do not give auto transfusion in our center. What we do is we immediately try to arrange for blood and we give that. Auto transfusion, I don't have much experience with, because at that time you're so stressed out and you're just pulling and giving. There's always a chance that you might put in some air and also maybe, hemolyze the blood. We personally don't have much experience with auto transfusion, but I believe that if it's desperate and you have no option, of course you can try it, but we don't do it on a regular basis or very infrequently.
Actually, auto transfusion is advocated when there is a tamponade, because you treat the tamponade as well as put the blood in. You are doing both. Right. Otherwise, it's not a choice of treatment.
No, that's right. That's not necessarily always you need an auto transfusion. It depends upon how the blood is leaking from the perforation. I have one very bad experience of that. In the Cathlab, in the arterial lesion, there is a perforation after putting up the stent, and then after that there is a cardiac tamponade. And at the time, one of my colleagues is trying to place the pictal catheter in the pericardial cavity. Then, unfortunately, that goes to the RV. And then and the sheath was introduced in the RV, and the blood is coming up and giving that, it is still not coming up. Then we have to fix up the RCA, but we cannot fix up the seal of that. Suddenly, patient was becoming violent, and the sheath was withdrawn from the RV. And that patient, we have to give the auto transfusion, and we send the patient for surgery, and it was repaired, and patient is improved and go home. So there is some situation. That is the cascade of the complication. In that case, I think so, or we can go for auto perfusion. But auto perfusion, we have to careful about that. What Fazila mentioned, sometimes embolism can go, but as you are going the venous route, so microembolism by small embolism should not be any problem. It will not create a problem. If it's got the arterial wall, then it's a problem, real problem. But if it is very small amount of the ear, it should not be any problem, I think so. But we have to careful about that, giving the blood, but we have to give it very quickly. So you have to take in one hand syringe and taking out and give quickly blood into the in the venous system. That you can do that.
Thank you, sir. Dr. Kaiser bhai,
a small comment on this.
Yeah.
There should be a mandatory to do echocardiography within the cath lab to monitor the amount of pericardium, not only in the cath lab. The patient should be monitored in CCU also, because you must see that it has been sealed, but gradually there is a chances of expansion of the effusion. So keep the indwelling catheter there in the pericardial space and monitor it to see the. You can also monitor the hemodynamics. That also give you a guide whether the fluid is accumulating or not. If there is further accumulation, there will be fall of blood pressure again. So patient should be monitored with echocardiography both in the cath lab and the CCU. That is my small comment on this.
Dr. Kaiser bhai, do you hear me?
Yeah, loud and clear. I've got some tech problem. Just 3 minutes. It's a brilliant presentation by Dr. Fazila Appa, as usual. Learned a lot from her, always. Secondly, nice initiative by IPDI, all the programs. Salute to you and your team, Odud Bhai and Mohsin and your team. Third thing, I will give 3 comments about complications. One, if you don't have any complication in your life, you are not doing enough cases. This is for juniors. Second, Second, if you have too many complications, that means you are not planning your case. You're not reading your case before. And third, everybody should have a complication kit in your cath lab, because when this happens, time matters. Time is life. So if you search for where is cover stand, where is the pigtail, where is that thing, you should have a pericardiocentesis trolley. You should have a cover stand coils in your one box, which is called complication kit box. These 3 things are very important for all intermittent cardiologists in his life. And just giving a comment about the last questions, that pericardiocentesis autotransfusions. So when the patient collapses, it's very important to give the fluid or blood. So autotransfusion is a measure before a fresh blood comes, but it takes time to collect a fresh blood. So the problem is that when you collect, pull up through a syringe and then give it, there is a chance of air embolism. So very easy technique is that you just connect the pigtail catheter's mouth with the cordage sheet of the venous system of your femoral vein with a connector. But problem is that they're all male. So you have to use a rubber sheet to connect them. As the pericardial effusion pressure is high because of pumping heart, it will automatically go from the pericardial cavity towards the venous system. You don't have to pull by syringe and push it again. It is automatically go. Just you connect that pigtail with the venous sheet of cordage sheet of the femoral vein. Thank you.
Thank you. Excellent demonstration. New technique for pericardiocentesis to the venous blood. Thank you, Dr. Sridhar Bhai.
Or Dr. Professor Arun is here.
Dr. Arun Maske. Dr. Arun Maske, welcome to our session. Please unmute.
Professor Arun from Nepal.
I joined a little late.
You missed a lot.
I'm a student of Fazila ma'am in NICBD. This was excellent presentation. I have one question. So, a 30-year-old gentleman came with acute inferior volume, no risk factors, occluded mid RCA, did struggle in Cathlab for 2.5 hours, did everything, balloon dilatation, thrombosuction, GP2V inhibitors, didn't respond. At the end, we left that patient with inotropic support. Patient becomes stable, discharged, and just for academic interest, did an angiogram after 6 weeks. This vessel was recanalized around 3 mm RCA. In the mid part of that vessel, there's an aneurysm around 5.6, asymptomatic. So how should I treat that patient?
It was your patient, Arun. Tell me, what did you do? You tell us what you did.
The patient had 32 years, occluded
yes. But the thing is, you did later on, you found that there was an aneurysm that was asymptomatic. So my question is, when you did that and you found the aneurysm, what did you do? You tell us. We learn from you.
I'm that patient medically now.
Exactly.
And my question is, how should I follow this patient? Do I need to do a CT scan just to see if the sizes are increasing? Or just treat patient medically, do nothing, see his symptoms? This is just young, 32 years old gentleman. I tried to use literature, I could not get answers. So this is my opportunity to ask my teacher.
So, we've got so many legendary figures here. We can ask, because this is a hypothetical question, Arun. And what I think is, whatever you're doing must be fine because your patient is doing well. So personally, if that were my patient, I would have asked him to do lifestyle modification, take care of himself and give up his statins. And obviously, I would give him dual antiplatelets. Whether I would do a CT to monitor his the aneurysm, I don't think I would. Would you do?
Dr. Professor Rahiduzzaman sir, do you hear me? Any comments? Aneurysm, follow-up of the aneurysm?
Aneurysm. Yeah, we are all interested to dilate a stenosed vessel, but rarely we think about to make small sized the aneurysmal segment. Yes, there is a option for treatment of aneurysm when you feel that there is a chance of rupture of the aneurysm. Usually, aneurysm itself will not produce any symptom as such, but the RCA, it's a infarct-related vessel. Even if you don't do anything to treat the vessel, nothing will happen. But if there is any chance of the chance of rupture, by if you see the follow up the monitor the patient by CT angio, and if you feel that it is increasing, then it should be tackled by putting a cover stent. That is my suggestion. Usually 1.5 times bigger than the original size is called aneurysm. But say, for example, the vessel is gradually increasing. So every 6 months you are doing CT angio, it is increasing. So there is a chance of rupture. In that case, simple procedure to put a cover stent that can prevent rupture of them. What actually the Fazila showed one patient to occlude the aneurysm means that it is just close the vessel by embolizing coil. Here, you don't need to embolize this. You just put a cover stent. That cover stent will seal the aneurysm if it is suitable with a cover stent. That is my suggestion.
So do you advise doing a CT angiogram regularly in this patient?
At least 6 monthly, you can.
Can I add one line?
One by one, Dr. Sir, just Khalid Bosin sir, raise his hand. Khalid Bosin sir, do you add something?
I from our experts that does the use of ETO treated or chemical treated predilation balloon plays any role in the creation of coronary artery aneurysm? Is there any such
etiology? Definitely
triggering.
No.
All balloon.
No, Khalid Mohsin যেটা বলতে চাচ্ছে যে অ্যানেউরিজমে তো একটা কারণ তো ইনফেকশন, ডেফিনেটলি ইনফেকশন তো একটা কারণই, কারণ আমাদের সাবকন্টিনেন্টাল অ্যানেউরিজম যত পাওয়া যায় অন্য সাবকন্টিনেন্টে পাওয়া যায় না। এখন এই জন্যই হলো কি ইট কুড বি যে রিউজ বেলুনে কিন্তু অ্যানেউরিজম হতে পারে, যদি ইনফেকশন হয় রিউজে কিন্তু হতে পারে। অনেক সময় হলো কি যে ব্লাড লেগে থাকে, সেটাকে ইটিও করাটা রিয়েলি ডিফিকাল্ট। আরেকটা স্টেন্ট দিয়ে হতে পারে, সেটা ওল্ড জেনারেশন স্টেন্ট, নিউ জেনারেশন মোস্ট অফ দি স্টেন্ট যেগুলো third generation, second generation. So I am agree with Rahiduzzaman bhai. Definitely, if the aneurysm size is less than 1.5, then we tackle with medication. We can follow up the patient by CT angiogram or other. But if the size is bigger, much more than, and there is a chance of the rupture, then I think so either we have to fix up with the covered stent, or if necessary multiple aneurysm. If there is a, then we can send the patient to surgery also. That's a different issue. But
also do you add something?
Somebody might think that there is a high chance of restenosis. So if you put a cover stent, there is a chance of restenosis. I think restenosis, that is not that light curtain compared to rupture of the aneurysm.
Right, sir. Exactly, sir.
I like to share with the Rahiduzzaman sir. Several years back, one of my relatives developed aneurysm at the distal end in the mediality. After putting a stent, appropriate post dilatation, everything have done, but it was little after 3 months develop little fever and some illness, acute illness, flu-like symptom. After that, we did the check angiogram, and there is a moderate size aneurysm in the distal end of the drug-eluting stent, third generation. I sent it to Rahiduzzaman sir, Monisha sir told that it is nothing to do. Flow is maintaining distally. And also I took the opinion from the surgeon. They are also not happy because single vessel disease and having aneurysm. But unfortunately, I like to share my experience that relative sudden cardiac death happened. So in my conclusion, aneurysm is the harbinger of cardiac arrest, acute LVF. When it rupture any port, BP fluctuation or any illness, acute illness or on any fever or any inflammation, then anything may be happen and sudden death is usually occur. So I think there is.
Amol, how many days? How many days actually the patient collapsed from the diagnosis?
Just after visit you, after within 6 months of visiting you.
Can I add something?
He has no symptom. Suddenly, one day, he is a father of doctors, and his daughter is in UK. So I feel nothing.
Sir, do you add something?
Sometimes the aneurysm could be microtic aneurysm due to related to infection. That may be related to, as Khalid Hossein Bhai was saying, could it be due to improperly sterilized reused material? That could be a reason. In those cases, you cannot be assured of the slow progression of the aneurysm because not only the hemodynamics, but also the inflammatory process is actually acting in the process of gradual enlargement of the aneurysm. In those cases, actually surgical intervention may be required earlier, but in this case, we have to have close follow-up by CT NGO. That will be better. Otherwise, as a whole, aneurysm progression is very slow most of the time.
Okay, last one. Dr. Sudhir Shah, do you hear me?
Yes, sir. Yes, sir. Yeah. Assalamu alaikum, sir. Thank you for giving me an opportunity to ask the questions. So, assalamu alaikum, ma'am. I would like to thank and congratulate you for the awesomely good presentation. You are really a unique presenter, and I'm letting you know that I'm a big fan of your accent. And you are a proof that age is just a number. I have a question regarding, it might sound silly, but it's regarding medical legal aspect of the hazards we might end up in the cath lab. Though it's a neglected topic in the country like ours, but the question is how we might be charged medical legally if we end up with coronary perforation or something like that, and unfortunately, we could not save the patient. This is the question.
I mean, that is a nightmare for all of us, isn't it? This can happen to anyone. You start a procedure, it's a simple thing, and then you lose your patient. That is a nightmare that no one wants to have. But if the consequences vary, right? Like if you have a good rapport with your patient and their relatives and all, and you have already explained to the patient that these are the potential, and the relatives also, these are the potential things that might happen. You have taken the consent, and also you have, and the patient's party is understanding, then usually they will accept the fate, right? But sometimes there are patients and relatives who can get very emotional, may even turn violent, and even cause breakage of hospital and all, and later even, manhandle a physician. So the spectrum is very wide. And if unfortunately for our part of the world, we do not have a safety net, the doctors do not, and I think today is a day when we have all such legends with us in the field of intervention cardiology in Bangladesh. We should, I think, create an insurance or a safety net or something. We have Bangladesh Society of Coronary Intervention, which is a great endeavor, and all of you have served there and have worked there and have elevated it to greater heights. But maybe, what he has pointed out is very relevant, and we should learn and take better steps to safeguard ourselves against certain accidents like this. What do you say, Professor Dr. Rahiduzzaman? Any comments?
That's a good question. Basically, now the time what we passed, safely we came up to this without much problem on us. Although I have still 2-3 case I am just
Dealing
my
with.
lawyer is going to court, but
Sufferings.
Sufferings is there. But I do believe the juniors, they are really in danger in future, because people, they know sometime in a way that they knows better than you by going to Google, going to YouTube. They explain you have done mistake like this way, you have not done this way. So there should be, first of all, you must be very much acquainted with the guideline. You should follow the guideline. You should not do something of your own. So guideline will protect you by law. Second one is that you should explain things detailed with the patient party, both pre, during, and after, so that they will at least absorb the possible even it happen in the best possible best operator in the world. It can happen, but if you cannot explain to the patient will not take it easily. They will bang on you. So there should be, first of all, you follow the guideline. Second, you should maintain a good conversation with the patient relative. Patient relative, I'm talking about patient relative, not the patient, because once the patient is in a crash, so he will not say anything. Patient relative. Third, definitely, many of the situation is because of comment given by our colleague. That is the fact. So I think it is a multifactorial. Definitely, legal protection is we need. If not for me, for you also. Everybody are at risk of having this problem in future. So it is, Fazila said that yes, there should be insurance coverage of all these things. That can at least financially you can protect. Otherwise, this not only your psychological trauma, it also financial trauma to you. Okay. So now it is a time to make a insurance, group insurance, whatever you say, to protect our junior cardiologist. This is my comment.
Thank you. We are already only 2 hours. We are passing through time. Dr. Arif, do you hear me? Dr. Arif, Dr. Abdul sir, Professor Fazila-Tun-Nesa, few comments.
Yes, comments হলো কি ইন্স্যুরেন্স মানে বাইরের সব দেশে কিন্তু ইন্স্যুরেন্স আছে, শুধু আমাদের দেশে নাই। কিন্তু ইন্স্যুরেন্স কিন্তু অবশ্যই থাকতে হবে, ইন্স্যুরেন্স মাস্ট। যেমন জামান ভাইয়ের কথা বললাম যে যেমন এনআইসিবিতে কিন্তু ওইভাবে 1:1 কিন্তু পেশেন্টকে করা মুশকিল, কাউন্সেলিং করা ভেরি ডিফিকাল্ট, কারণ পেশেন্টের লোড বেশি থাকে। আমি এনআইসিবির কথাটা বলছি আর কি। কিন্তু আই হ্যাভ এন এক্সপেরিয়েন্স, যেটা হলো কি যে ঠিক একই কথা, একটা পেশেন্ট অ্যানজিওগ্রাম সেটা করছে, সেই সময় আমার যে অ্যাসিস্ট্যান্ট প্রফেসর ছিল সে অ্যানজিওগ্রামটা করছে। সে পেশেন্টটা হলো কি জাস্টিসের আত্মীয়, উই ডোন্ট নো দ্যাট অ্যাবাউট। যাই হোক, সেই ডাক্তার আবার সেই জাস্টিসকে কেবিনও দিছে, দেওয়ার পরে সে অ্যানজিওগ্রামটা সে নিজেই করছে। নিজে করার পরে রাত্রিবেলায় যখন হলে কি পেশেন্টের পরশিশুতে গেছে, পরশিশু যাওয়ার পরে পেশেন্ট হলে কি চলে গেছে অন্য হসপিটালে। অন্য হসপিটালে যাওয়ার পরে সিরিটা দেখে ডক্টর বলছে যে আসলে সিরিটা তো বেশি ভালো হয়নি। অ্যান্ড দেন ওই জাস্টিসটা গিয়ে কোর্টে আমার নামে কেস করে দিছে যে ডক্টর নিজে না করে তার কি অ্যাসিস্ট্যান্টকে দিয়ে করাইছে। দিস ওয়াজ দ্য কেস ফাইল এগেইনস্ট মি। আনফরচুনেটলি সেই কেস আবার থানাতে যায়। থানাতে যখন গেল, থানাতে পুলিশে পাঠালো এনআইসিবিতে। এখন এখানে তারা আছে কিনা, তখন তারা বলছে দেখেন আমার বাবার যদি অ্যানজিওগ্রাম হতো তাহলে আমরা তাকে করতাম। এন্ড আফজাল স্যারের বিরুদ্ধে কেন কেস করছে সেটা আমি জানি না। ফরচুনেটলি উইদিন 1 month the justice was died and the case was diminished and I rescued that. That is the history actually. This is the happening. কাজেই জামান ভাই, কাজে কিন্তু প্রোটেকশন কিন্তু ফজিলা যেটা বলছে, আই মাস্ট, আপনি যেটা কাউন্সেলিং করেই বা আমরা করতেইছি, তারপরেও কিন্তু বেশি অনেক কিছু থাকে যেটা হলে কি প্রোটেকশনের জন্য আমাদের কিন্তু দরকার, লিগ্যালিটি দরকার, আমাদের সোসাইটি, আমাদের লিগ্যালিটি কিন্তু দরকার। দ্যাটস ইম্পর্টেন্ট। কিন্তু আমাদের একটা লিগ্যালিটি লয়ার দরকার, বিশেষ করে আমাদের নিজস্ব।
I think society can initiate these things.
হ্যাঁ, আমার মনে একটা লয়ার থাকা উচিত। কার্ডিয়াক সোসাইটি ক্যান ইনিশিয়েট দ্যাট। কার্ডিয়াক সোসাইটি ইজ আ বিগার ব্রাঞ্চ। আমার মনে একটা লয়ার কুড বি ইন দ্য ফিউচার।
Anybody can be the victim. Anybody can be the victim.
আমি এখানে মমিনুজ্জামান স্যার এবং আফজাল স্যারের সাথে টোটালি একমত যে আমার মনে হয় যে বাংলাদেশ কার্ডিয়াক সোসাইটি এবং বিএসসিআই অলসো ইজ এ বিগ সোসাইটি। আমরা এটা পরবর্তীতে এটা একটা আলোচনা করতে পারি যে আমরা একজন লয়ারকে ইয়ে করা, আর একটা হচ্ছে যে ইন্স্যুরেন্সের ব্যাপারটা আলোচনা, একটা ভালো জিনিসটা একটা এখানে উত্থাপন হয়েছে স্যার। আমরা আফটার করোনা হয়তো ইয়েতে মিটিং গুলোতে এটাতে আমরা হয়তো এটা আলোচনা করতে পারি স্যার।
এখানে আরেকটা জিনিস যেটা হচ্ছে, যেহেতু এখন অপশন আছে, কায়সার যদি একটু ফ্রি থাকো, নূর আলম আছো, অমলদা আছেন, যে আমাদের লিগ্যাল প্রোটেকশনের জন্য কিছু লিগ্যাল ল্যাঙ্গুয়েজ দরকার, যে সেগুলোর ব্যাপারে একটু করলে ভালো হয়। যে একটা আমরা যেটা কনসেন্ট পেপার যেটা নিই প্রসিডিউরের জন্য, সেটা লিঙ্গুইস্টিক কি হওয়া উচিত, স্টেপ্টোকাইনের জন্য কিরকম হওয়া উচিত, একটা ইউনিফর্ম কনসেন্ট ফর্ম যদি আমরা তৈরি করতে পারি থ্রু আওয়ার সোসাইটি, দ্যাট উইল বি মাচ বেটার। As Sir was saying, if it is Monojan Bhai was saying, if it is directed by a society as a guideline or guidance, that will be a legal protector for everybody.
Kaisar bhai, do you add something? Dr. Kaisar?
3 points. একটা হলো যেটা অদ্ভুত বললো, একটা লিখিত কাগজ থাকতে হবে। আমরা আমাদের হসপিটালে করছি এটা একদম বাংলা কথায়, বাংলা এবং ইংরেজিতে, যে ওখানে লেখা থাকতে হবে রোগীর মৃত্যু হতে পারে, এই কথাটা ক্লিয়ারলি লেখা থাকতে হবে, বলতে হবে। আমি কিন্তু আমার রোগীকে বলি এখানে 1% চান্স আপনি মারা যেতে পারেন। আর খারাপ রোগীগুলোকে আমি বলি আপনাকে লাশ নিয়ে ঘরে যেতে হবে, 10 লাখ টাকা খরচ হবে, হ্যাঁ বলে আমি আগাবো, না বলে নাই। বাংলা কথা, এখানে কোনো রাগ ঢাক নেই। কারণ হলো কি, এভাবে না বলে রোগীরা বোঝে না। আর লিখিত দরকার হবে, কারণ পরে রোগীরা উল্টা যায়, সাইন থাকলে তখন সে উল্টালে বলতো এই আমি নিয়েছি। এবং আমি যখন কাউন্সেলিং করি, আমি একটা রুমে করি, যে রুমের উপর একটা ক্যামেরা আছে, ওখানে রেকর্ড হয়, এবং আমি রোগীকে বলে নিই এই রুম রেকর্ডেড, যাতে পরে যদি সে উল্টে যায় ডকুমেন্ট থাকে। 1 2 নম্বর যে কথাটা মামুনুজ্জামান স্যার বললেন, নিজেদের কলিগকে যদি কিছু বলতে হয় সেটা আপনি ফোনে বলেন, এটা আপনি ফোনে বলেন, রুগীকে বলেন না। রুগীকে বলে আপনি শুধুমাত্র নিজের সহযোগীকে ছোট করতেছেন। এরকম অনেক ঘটনা করছে, একটা না। আমি যখন 5 সেকেন্ড, আমি এখন তো নাই, যখন ছিলাম আমি, তখন আমি এরকম একটা না, আমি বলবো কমপক্ষে 10 থেকে 15টা আমি কেস পেয়েছি, যেখানে আমার কলিগ আরেক কলিগের এগেনস্টে মানে কিছু বলেছে। আমার প্রয়াত ফ্রেন্ড লিটু, ও একটা প্রবলেম পড়েছিল, ওর নাম বললাম বিকজ ও মারা গেছে। ওর এই প্রবলেমেও ও আমাদেরই কিছু কলিগ কিছু কমেন্ট করেছিল, যেটা করা ঠিক না। ভুল আমি করতেই পারি, আমি মানুষ, আমাকে আপনি বলতেই পারেন, বড় ভাই ছোট ভাই ফ্রেন্ডকে বলতে পারেন, আলাদা করে ফোনে ডেকে বলেন, রুমে ডেকে নিয়ে বলেন, কিন্তু রুগীকে বলাটা মোটেই ঠিক না, ভুল সবাই করে। এটা আমার সেকেন্ড পয়েন্ট। আর থার্ড পয়েন্ট, উই নিড এন লিগাল অ্যাডভাইজার who will be appointed from BSCI অথবা কারি সোসাইটি। তাকে একটা মান্থলি অ্যালাউন্স দেওয়া হবে, পয়সা ছাড়া কোনো কাজ হয় না। যখন কেস আসবে তখন তাকে একটু বেশি দেওয়া হবে, এটা দরকার, সব জায়গায় আছে। থ্যাংক ইউ।
একটা এক্সপিরিয়েন্সের কথা বলি। লিটুরি কেস সে একটা পেশেন্টকে বলেছে ওর 70% লিশন আছে, এটা পিসিএ করা দরকার, রোগী সিমটোম্যাটিক। ওটা আরেকজন দেখে বলছে, জুনিয়র একজন ডাক্তার দেখে বলেছে যে না, এটা আসলে প্রায় নর্মাল কোরোনারি। কেন বললেন? রুগী গিয়ে করে প্রেস কনফারেন্স ইত্যাদি করেছে। আমি সব শুনে সেই সিরিজটা জোগাড় করলাম, করে দেখলাম there was an eccentric lesion in LAT which was seen best only in allocranial view. The junior doctor missed it totally, and it was very much correct. আমি তখন যে করলাম যে তোমরা যেটা করছো দয়া করে ওদেরকে জানা আসে জিনিসটা এরকম। That's why I always tell my students, if you are giving a description of an eccentric lesion, please mention this is best seen in this view. So someone else who is seeing the CT will not make a false statement or may implicate you in an embarrassing situation.
এটা এখানে এখন একটা সুবিধা আছে কি, আমাদের এখন সব ক্যাথল্যাবে কিন্তু কিউসি আছে, সুতরাং if you exactly freeze that one and QCA and keep it as a document with the CD, it will be there. So it is another backup support of your comment.
That's a good idea. That's a good idea.
No, only 30 seconds and only 20
Actually, I learned a lot from today's session, especially the last issue, the legal issue which is raised. Of course, we will raise in our EC meeting both BCS and BSCI. I am also a fan of ma'am like Shudhir. When ma'am presented in a left main series, actually it was amazing when ma'am present left main series. Thank you, ma'am. Just I would like to know on issue, I don't know if this is relevant or not, but how you tackling Cathlab procedures in this COVID COVID era? Just your Cathlab approaches in COVID era. Just like to know in Heart Foundation.
In Heart Foundation, what we are doing basically nowadays, we are doing acute coronary syndrome patients, like mainly patients come with ST segment elevation MI or some other acute coronary syndrome. They're symptomatic. So after we've given them medical treatment, we send for their COVID test. Once the COVID test comes, only when it comes negative do we take them to the Cathlab to do angiogram and if required to do PCI. So basically, acute coronary syndrome patients who are hospitalized and who are not responding to treatment, medical treatment, are still symptomatic. Only after COVID testing are we doing their PCI and angiogram. So like today we did 6 PCIs and these were all acute coronary syndrome patients.
Thank you. Thank you. Last question from the Dr. Abdullah Al-Manjur. Dr. Abdullah Al-Manjur, do you hear me? Dr. Manjur?
Manjur, unmute. Yeah.
Okay. Last question. Dr. Manjur? We not hear you.
We do not hear you, Manjur. Manjur, we could not hear you.
Dr. Arif, do you hear me? Dr. Arif?
Sir.
Your last question from the chat box.
Okay, sir. There is an interesting question from Virat. He wanted to know when we have planned for put a covered stent, but size is not available. In that case, whether we can convert in your conventional stent to a covered stent, in any technique there?
Yes, actually, there is. It was presented in TCT last year from our hospital, and you take a balloon, cut the balloon piece, and basically between 2 stents you place the balloon. So you have to have a double layer of balloon there. So you take 1 stent out, there is your balloon, and you put the layer and you put the second stent there, crimp it over, and then take it. But it's very bulky. You know, if you make a homemade covered stent, it is usually very bulky and it is difficult to take. So that is a challenge.
And I think it's also risky also.
Dislodgement of the stent.
Definitely. So a homemade cover stent I would not recommend. It's always smart to have the cover stents ready on the shelf. But if you have no other option and you can do that. You have, this is your last measure, then
you can do that. Yes, definitely.
Thank you. Thank you.
Thank you.
This is Dr. Mahmoud Caesar bhai. Mahmoud Caesar, do you tell something?
Thank you, IPD, for nice organizing this type of session. And again, the madam is excellent regarding her deliberating, informating speech. Thank you.
And thank you, everyone. Thank you so much.
Wadu sir, we have already left more than 2 hours time.
Thank you.
Yeah. We have had a very good time indeed.
Thank you.
We have met so many of our colleagues, friends, teachers,
can you give any information
juniors.
about our friend or junior already suffering from COVID? How is Jamal? How is Manzoor?
Jamal bhai has gone to
Jamal sir, bhalo ache sir.
Manzoor
is
he also improving, sir.
Manzoor is okay.
এখন পর্যন্ত সবাই মোটামুটি স্টেবল আছেন, যারা কার্ডিয়াক সার্জারি যারা হয়েছেন। ওদিকে সমীরণও ইমপ্রুভ করেছেন, স্টেবল হয়েছে।
সুমনও তো ভালো আছে বটে বাদুচ্ছেন।
সুমন ভালো আছে, ও সব প্যারামিটার গুলো ইমপ্রুভ করে গেছে খুব তাড়াতাড়ি। So far so good. That's good news. The thing is, many of our doctors working in Dhaka Medical College, the 4th and 5th batch, around 25 of them has become infected among 85 doctors. So that means around 50 doctors are infected. Almost all of them are asymptomatic.
Sir, Professor Jalal sir want to say something. Professor Jalal sir.
একটু কথা বলছি এই জন্য যেহেতু আজকে ডক্টর মমিনুজ্জামান as well as Dr. Kaisar is here today for the first time, and I am very happy that Dr. Kaisar has recovered from his illness. Dr. Maminuজ্জামান the other day told me that when he started doing the angioplasty for the first time in Bangladesh in NICVT, he lost the
stent.
First stent I lost.
First stent. That is
right coronary artery proximal.
That is
that was the Johnson and Johnson. First Johnson and Johnson is a government.
Yes.
No, cover long cover the delivery sheet. The new. I think the Wadud. I think you have not seen that. The whole stent with balloon was covered with a long sheet. How to handle it.
Dr. Maminuজ্জামান
And over the balloon. And
yes,
over the balloon.
Yes. Dr. Maminuজ্জামান told me that later on I gave him more patients to continue. That at that time I was director of the hospital, and it was my duty যে আমার স্টুডেন্টকে আমার হাইলাইট করা, even he is in problem, আমাকে তার হাইলাইট করা, হাইলাইট করতে করতে আমি তাকে অনেক করছি, অ্যাপ্রিশিয়েট করছি, এবং later on he did very well in his intervention site in Bangladesh. Not only that, later on what happened, one night I had pain in chest, and within 15 minutes at late night or just midnight, I went to Dr. Maminuজ্জামান in United Hospital. On the way, that my chest pain disappeared, and because when I was getting chest pain, immediately I took 4 tablets of Ecospin, which I was continuing from before. ঠিক এবং বারবার আমি স্প্রে নিচ্ছিলাম, নাইট্রেট স্প্রে নিচ্ছিলাম। তো যেতে যেতে রাস্তায় দেখি যে আমার চেস্ট পেনটা কমে গেল। তারপর ওখানে যাওয়ার ইমার্জেন্সি গেলাম। ইমার্জেন্সি যাওয়ার পরে আমি বললাম যে আমি তো এখানে, ডাক্তার আমাকে ভর্তি করে নেন। ডক্টর মমিনুজ্জামান, ডক্টর কায়সার, ডক্টর আমার স্টুডেন্ট ডক্টর ফাতেমা ইজদার, আই ওয়াজ ভেরি মাচ, আমি খুব সাহস পাচ্ছিলাম যে তারা 3 জন very good cardiologist was here, and Maminuজ্জামান was leading the position at that time in United Hospital. আমাকে ভর্তি করে দিল। তখন মমিনুজ্জামান ছিল না, ওই দিন তারা ইসে যাওয়ার কথা, ওই সিলেট। তা আমাকে ভর্তি করা হলো ওই রিয়ানের আন্ডারে। Dr. Rian was working with me in Leavitt Hospital for a long time. I was very happy with her also. তারপরে সকালে early morning, Dr. Maminuজ্জামান as well as Dr. Kaisar came to see me, and they are going to Silet. I told him we go to Silet, যেহেতু এখন ব্যথা নাই, ব্যথা কমে গেছে, I'm okay now, you come back and then see. ঠিক তার পরের দিন সকালে তারা আসলো। আসার পর দুইজনে আমাকে দেখলেন। তো মমিনুজ্জামান বললেন যে স্যার আপনার অ্যাঞ্জিওগ্রাম করতে হবে। হ্যাঁ, আমি ডেফিনেটলি আমাকে অ্যাঞ্জিওগ্রাম করতে হবে। I don't know what is happening to me. তো তখন ওই আমার troponin was negative. তো আমি একটু সাহস পাইলাম যে তাহলে বোধহয় আমার বড় এমআই কিছু হয় নাই। তারপরে অ্যাঞ্জিওগ্রাম যখন করা হলো, অ্যাঞ্জিওগ্রাম করার আগে আমি বললাম যে আমি বয়স এখন 76, আমার মেবি ইট ওয়াজ ভেরি কমপ্লিকেটেড ওয়ান। এই যে আমরা বারবার বলি, ডক্টর মমিনুজ্জামান বলছে, ডক্টর ফজিলাও বলছেন, প্রফেসর আফজালও বলছেন, যে টিম ওয়ার্ক ইজ ভেরি মাচ এসেনশিয়াল। I told Dr. Maminuজ্জামান that you can also ask Dr. Kaisar to be with you when my angiogram is done, because maybe very complicated one. You can discuss together. Dr. Mohammed was very happy, and Kaisar was also very happy to be over there. Then তারা angiogram করে বললো যে আমার দুইটা স্টেন্ট লাগবে, একটা রাইট কর্নারি as well as in the left LED. আমি খুব একটা শুনতে করছিলাম না, আমাকে একটু যেহেতু সিটেশন দেওয়া হয়েছিল এই অবস্থা, আমি বললাম যে ঠিক আছে ঘুমের মধ্যে পড়লাম। তারপর সুন্দরভাবে তারা খুব অল্প সময়ের মধ্যে অ্যাঞ্জিওগ্রাম মানে স্টেন্ট দুটা লাগাই ফেললেন। তখন আমি চিন্তা করলাম যে I was his teacher, and today I am so fortunate to utilize my student to implant 2 stents in my coronary arteries, and I felt very much happy, and I express my gratitude to both of my students that they saved my life in the by the grace of Almighty Allah.
Actually, sir, আমরাই আপনার প্রতি grateful.
I am so happy today that I was teaching my students, both Mohammed as well as Dr. Kaisar, and also Dr. Rian over there. Fatima was out of station at that time, and thank you very much. I feel my again and again gratitude to my students, Dr. Mohammed, Dr. Kaisar.
বলছি স্যার, আমরা সবসময় আমরা আপনার প্রতি ঋণী, কারণ আপনারা আমাদেরকে এই সুযোগটা দিয়েছিলেন বলেই আমরা আজকে বিগডেস স্যার যদি এই হাসপাতাল না করতো, আমরা এমডি করতে পারতাম না, আমরা এখানে আসতে পারতাম না। সো আপনারাই আমাদেরকে এই সুযোগটা করে দেয়, এই জন্য রিয়েলি গ্রেটফুল টু ইউ
স্যার। সত্যি থ্যাংক ইউ স্যার, আর থ্যাংক ইউ স্যার। স্যার আমরা সবাই কিন্তু আপনার ছাত্র ছাত্রী স্যার, আপনি শুধু কৃতজ্ঞ স্যার ওই দুজনের কাছে, কিন্তু আমরা স্যার সবাই আপনার কাছে কৃতজ্ঞ। আপনার জন্য আমরা সবাই কৃতজ্ঞ স্যার, আপনি আমাদের ভালো টিচার ছিলেন স্যার, এখনো আছেন। থ্যাংক ইউ স্যার।
Thank you.
Last comment from the Professor Abdul-Rahman sir, and then go to the Professor Wadud sir.
Okay, thank you very much.
এই জন্য আমি একটু আগে বলেছিলাম যে প্রফেসর ব্রিগেডিয়ার মালিক সাহেব আমার টিচার ছিলেন ইন পিজি হাসপাতাল। তারপর যখন উনি এনআইসিবি স্টার্ট করলেন 1978, আই কেম ব্যাক আফটার। আমি যখন ভিয়েনা যাই 78-এ আমি ভিয়েনা যাচ্ছিলাম, স্যারকে বললাম স্যার আমি তো কার্ডিওলজি ট্রেনিং এ যাচ্ছি। স্যার আমাকে বললেন যে ট্রেনিং করে তাড়াতাড়ি আবার ব্যাক করে চলে আসে, এখানে জয়েন করেন। এসে ব্যাক করে এসেই স্যারের সঙ্গে দেখা করলাম, এবং কয়েকদিন মধ্যেই ওনার হেল্পে আমি এখানে জয়েন করলাম যে as the second man of him. So it was my great opportunity to be a cardiologist under his guidance. আমি যে এই পর্যন্ত আসছি, যতটুকু আমরা উঠতে পারছি, it was my luck and also the help of Professor Brigadier Abdul Malik. উনি যদি ওই সময় ইনস্টিটিউট না করতেন তাহলে আমার এই পর্যন্ত আসা হতো না। এবং থ্যাংক ইউ ভেরি মাচ টু অল।
আমানুল্লাহ স্যার কিন্তু খুবই অসুস্থ,
হ্যাঁ,
তার আবার একটা স্ট্রোক হয়েছে, এখন কমপ্লিটলি ডিমেনশিক, রাইস টিউব দিয়ে খেতে হয়, রিয়েলি সে খুবই খারাপ অবস্থা। আমরা সবাই তার জন্য একটু দোয়া করবো। বেঁচে আছে মাত্র কয়েকজন।
আমি খুব দুঃখ পাইছিলাম যখন আমি জানতে পারলাম যে প্রফেসর আবু জাফর সাহেব ইউনাইটেড হাসপাতাল ভর্তি হচ্ছে। আমি মোহাম্মদ জামানকে বললাম যে আমি কি একবার দেখতে আসতে পারবো? ডক্টর মোহাম্মদ জামান বলে স্যার আপনি আসবেন না, তার কারণ হলো ওনার কাছেই করোনা পেশেন্ট আছে। তো আমার এত খারাপ ছিল যে মানুষটার সঙ্গে আমি এত বেশি ইন্টিমেট ছিলাম, এত বছর একসঙ্গে কাজ করেছি, সেই মানুষটাকে আমি শেষ পর্যন্ত তাকে একবার দেখার সুযোগ পেলাম না। এট দি সেম টাইম এখন প্রফেসর গত 3 মাস যাবৎ আমি ঘর থেকে বেরোচ্ছি না, ইভেন আমি উপরের তালা থেকে নিচে তালাও যেতে পারছি না। কন্ডিশন ইজ সো, এখন আমরা তার জন্য একটা দোয়া করি সবাই যে প্রফেসর আমারও সাবজেক্ট ভালো।
আফসার স্যার প্লিজ।
আফসার স্যার।
No, past হলো কি thank you the speaker ফজিলার প্রেজেন্টেশন সব সময় তো অ্যাজ ইউজুয়াল গ্রেট প্রেজেন্টার আর কি, and very nicely প্রেজেন্ট করছে আর কি, আর ভেরি ইন্টারেক্টিভ সেশন। আর সিনিয়রদের প্রতি জালাল স্যারের আমি সরাসরি অ্যাসিস্ট্যান্ট প্রফেসর অনেকদিন কাজ করছি, আমি জাফর স্যারের অ্যাসিস্ট্যান্ট এসেছিলাম, মালিক স্যারের সাথে আমার কাজ করার সুযোগ হয়েছে। আমি যখন স্টুডেন্ট ছিলাম তখন মালিক স্যার ডিরেক্টর ছিলেন, কাজে আই হ্যাভ অ্যান গ্রেট অপরচুনিটি টু ওয়ার্ক উইথ হিম। সো আই এম রিয়েলি গ্রেটফুল। এবং আমি এনআইসিবির সব কিছুই দেখছি যে হাউ দ্য এনআইসিবি ইজ কামিং আপ, হাউ দ্য এনআইসিবি বিল্ড আপ, পুরান বিল্ডিং নতুন বিল্ডিংয়ে কীভাবে যাওয়া হলো, কীভাবে গেল। এবং জাফর স্যার আমাকে অর্ডার একদিন করলো যে আজকের মধ্যে আপনাকে সিসু শিফট করতে হবে এরশাদের সময়। আই হ্যাভ টু শিফট দ্য এনআইসিবিডি উইদিন ওয়ান ডে। ইট ইজ দ্য হিস্ট্রি আর কি। মোল্লা ছিল ওই সময়, মালিক স্যার যখন চলে গেছেন, মালিক স্যার রিটায়ারমেন্ট করছেন, তারপর জাফর স্যার ডাইরেক্টর হলেন। যাই হোক, আমরা সবার প্রতি গ্রেটফুল, জালাল স্যারের প্রতি আরও গ্রেটফুল, কারণ জালাল স্যারের সাথে আমি অ্যাসিস্ট্যান্ট প্রফেসর ছিলাম। আর আজকে আমাদের কলিগদের সাথে ইন্টারাকশন করে রিয়েলি ইট ইজ অ্যাপ্রিসিয়েট করার মতো আর কি। থ্যাংক ইউ অদুদ অ্যান্ড থ্যাংক ইউ মহসিন ফর অ্যারেঞ্জিং অ্যান্ড ইনভাইটিং মি, অ্যান্ড থ্যাংক ইউ এভরিবডি।
Thank you. Before Wadud sir, I just appeal, we know COVID-19 situation is so much getting worse day by day in Bangladesh. So our frontliners, colleagues, seniors, juniors are so much work in the heightened risk. So we should do for our colleagues and everybody. IPDI takes some initiatives. We've just group of doctors from the chest physicians and also internists, critical medicine. We are doing a group of doctors doing for the juniors. A few, we are just a step for few things for do. What to do? একদিন এক জুনিয়র ফোন করে আমাকে রাত 2টায় বলছে যে স্যার আমি বাঁচতে চাই, আমি আগামী বছর হজ করে মরতে চাই রাত 2টায়। এই যে একটা ছেলের সাথে আমরা কানেক্ট করছি রাত 2টায় 3টার সময়, আমি ডক্টর আরিফ, ডক্টর তানভীর, ডক্টর তুষার, এবং তারা কথা বলছে আমাদের সাথে। এতটুকু আমরা একটা সেতু বন্ধন করতে যাচ্ছি জুনিয়রদের সাথে, কলিগদের সাথে যাচ্ছে। এবং ওয়াদুদ স্যার আমাদের সময় দিচ্ছেন, ডক্টর ওবেদ আমিন, আমরা আব্দুল সাথে কথা বলছি ফোনে, স্যার কি করতে পারি। এবং এখানে আমরা সবাইকে অনুরোধ করব যে আপনারা প্লিজ একটা হোয়াটসঅ্যাপ নম্বরে ক্লিক করবেন, আমরা চেষ্টা করবো আপনাদের পাশে থাকার জন্য। আমরা এর মধ্যে কিন্তু অনেককে আমরা পাঁচ অক্সিজেনটা বাসায় দিয়ে এসেছি, আমরা অক্সিজেন সিলিন্ডার দিয়ে আসতেছি, আমরা চেষ্টা করতে চাই সামথিং। আমরা জানি অনেকেই করছেন, তবে আমরা চেষ্টা করছি উই শুড ডু ফর দ্য জুনিয়র্স এন্ড কলিগস বিকজ already we lost 62 doctors in Bangladesh. I don't know next month we lost how many doctors in near future. So I appeal everybody, please do for something for the colleagues. They are frontline fighters. We raise our voice to the government and non-government for doing this. Thank you, sir. Wadud sir, please comments on that.
আসলে আজকাল যে অবস্থাটা চলছে এর মধ্যে এই ধরনের প্রোগ্রাম করাটা যে কত বড় মানসিক স্থৈর্যতা এবং প্রয়োজন হয়, মনোযোগ ধরে রেখে এই ধরনের প্রোগ্রাম করা খুব কঠিন হয়ে যাচ্ছে। মসজিদ যেটা বলছিল, আমরা শিওর না যে আগামী মাসে আমাদের কেউ হয়তো এফেক্টেড হবে না, তার কোনো নিশ্চয়তা নেই। এবং অলরেডি আমরা ৬২ জন ডাক্তারকে হারিয়েছি। সেটা থাকলেও প্রবলেম থাকবে এবং প্রবলেমের মধ্যে আশা নিয়ে আমরা বেঁচে থাকবো। এই আশার জন্য আলো হিসাবে কাজ করবে এই যে আজকে প্রফেসর ফজিলা-তুন-নেসা মালিক যে একটা অসাধারণ লেকচার দিলেন, তা কিন্তু আমাদের শুধুমাত্র আমাদের জ্ঞান বাড়ালো, অভিজ্ঞতা বাড়ালো, কাজের ক্ষমতা বাড়ালো সেটা না, আমাদের মনে কিন্তু আশাও জোগালো। আমরা আশা হারাবো না, আমরা সামনে গিয়ে যাব। আজকে এখানে আমাদের সবার গুরু জালাল স্যার এত মনোযোগী ছাত্র হিসেবে এখানে ছিলেন। আজকে এখানে লিজেন্ডারি ইন্টারভেনশনিস্ট মমিজন ভাই আছেন। আজকে এখানে অসাধারণ অর্গানাইজার এনএসিবিটি প্রাক্তন ডিরেক্টর আব্দুল রহমান স্যার আছেন, আমাদের একদম জুনিয়ররা আছেন। এই যে খুব অ্যাক্টিভ যারা আছেন, যেমন আমাদের নূর আছে, আমাদের এখানে আসাদুজ্জামান আছে, এই যে সবাই মিলে যে আমরা চেষ্টা করছি, এটা কিন্তু টু কন্টিনিউ অ্যাজ গুড ডক্টরস। মমিজন ভাই একবার বলেছিলেন উনি ওনার মায়ের এনজিওগ্রাম করেছিলেন, তো সেটা নিয়ে কথা হচ্ছিল। আমি ওনার মায়ের প্রাথমিক ভর্তি হওয়ার পরে কেয়ারের দায়িত্বে ছিলাম। মমিজন আমাকে বললো, আমি যদি আমার মায়ের এনজিওগ্রাম করার ক্ষমতা না রাখি তাহলে আমি অন্যের এনজিওগ্রাম কিভাবে করব। উনার সে আলোকবর্তিকা ধরে আমি কিন্তু আমার সব আত্মীয় স্বজন, আমার নিজের শ্বশুরের, আমার নিজের ভাইয়ের সবার এনজিওগ্রাম, এনজিওপ্লাস্টি এগুলো করেছি, পেসমেকার এগুলো সব করেছি উনাদের শিক্ষা থেকে। ফজিলা আপা নিজের স্বামীর করেছেন। যে এই যে জিনিসগুলো আমরা যে করছি, শিখছি, এটার জন্য আমাদের থাকে। এই যে স্যার বলছিলেন আজকে জালাল স্যার যে আমাদেরকে আলোকবর্তী থেকে জ্বালিয়ে গেছেন, তার ধরে কিন্তু আজকে মমিনুজ্জামান ভাই, আফজাল স্যার, ফজিলা আপা এরা উঠে আসছেন, তাদের পরে আমরা উঠে আসছি। আমরা কিন্তু এই অনুষ্ঠানগুলোর মাধ্যমে সেটাই করে যেতে চাচ্ছি। আমি অসুস্থ হলে যেন আমার ছাত্র আমাকে সুচিকিৎসা দিতে পারে, আমি সুনিশ্চিতভাবে তার হাতে নিজেকে সমর্পণ করতে পারি। সেই আশা নিয়ে, কোভিড থেকে বেঁচে থাকার আশা নিয়ে, আল্লাহর রহমতের আশা নিয়ে আজকে এখানে শেষ করছি।
Thank you. Thank you, everybody. Assalamu alaikum.
Thank you very much. Thank you. Thank you. Dear participants, respected faculties, thank you, especially Professor Fazila Madam. Excellent presentation. Also, Monijaman sir, Jalal sir, Abdul sir. আসলে আমরা শুরু করেছিলাম আইপিডিআই অনেক আশা নিয়ে, কিন্তু এখন কিন্তু প্রতিটা ক্লাস করতে যে আমার খুব কষ্ট হয়ে যায়, কারণ যখন ডক্টর মনোয়ারের আমরা জানাজা পড়ি তখন আসলে পরবর্তী ক্লাস আমার জন্য করে চালিয়ে যাওয়া খুব কঠিন হয়ে যায়। আসলে প্রতিদিন এভাবে ফোন আসতে থাকে, ইট ইজ টাফ টু কন্টিনিউ। প্লাস ওয়াদুদ স্যার যেটা বললেন, উই শুড কন্টিনিউ বিকজ ইট ইজ আওয়ার রেগুলার ওয়ার্ক, বাট আমি জানি না যে এখন আমাদের ফিউচারে কি যাবে। তবে থ্যাংকস এভরিবডি, ডিয়ার পার্টিসিপেন্টস। এর মধ্যেও প্রায় 200 কজ করেছিল পার্টিসিপেন্টস। থ্যাংকস এভরি পার্টিসিপেন্টস, everybody. Our next class is a different type class. Yeah, one of the pioneer lecturer, Dr. Onil Saxena. Onil Saxena is the right person to talk about pacemaker. It is all the ABC for the pacemaker for the juniors. I think on the Sunday at 3 p.m. Dr. Onil Saxena is here. Till then, goodbye. Assalamu alaikum. Stay home and take care. Thank you.
Thank you. Thank you.
Assalamu alaikum.
I thank also Dr. Incepta Pharmaceuticals. I missed Incepta doing a lot for last 1 month, and Dr. Arif also doing a lot. Thank you, everybody.
Thank you, sir.
Thank you.